Good morning. Welcome all of you for the free paper session. We have 5 oral presentation lineup for today. I just want to tell you for the presenters that the allocated time is 10 minutes, 8 minutes for the presentation and 2 minutes for the discussion. At 8 minutes, automatically the screen will go black. So you can't proceed with the presentation after that, and then we have to go for the discussion session. Right, the first presentation is, the topic is high impact of non-communicable disease on overall mortality and health statistics in Sri Lanka. The authors are Priyankara S, Anuttara T, Bowatta G, Yasaratna D, Dharamgate S, Dharmaratna S. The paper is, the presenter please come and present the paper.
Good morning, ladies and gentlemen. I will be presenting our study on high impact of non-communicable diseases on overall mortality and health statistics in Sri Lanka. Incidence of non-communicable diseases and their health impacts are on the rise globally and nationally. Therefore, identifying mortality patterns and trends in different disease categories over years in Sri Lanka is important. Sri Lanka has mainly used death rates in healthcare planning. Though it's an important parameter in assessing health impact, death rates are highly influenced by deaths among the elders. Years of life lost is sensitive to premature deaths. Therefore, it becomes a vital statistic for analyzing preventable loss of life. In our study, 3 broad disease categories, communicable diseases, NCDs, and injuries were considered, and the underlying cause of death was coded using the International Classification of Diseases 10th revision. Objectives of our research were to identify mortality trends in Sri Lanka over the period of 1997 to 2014, to describe the main disease categories causing premature mortality, and to calculate age and gender-specific years of life lost for the above disease categories. Moving on to methodology, for the years 1997 to 2014, we obtained data regarding registered deaths from Department of Census and Statistics, Sri Lanka. For each selected disease category, age and gender-specific death rates were calculated. In order to compare between different population groups, age-standardized years of life lost death rates were calculated using WHO standard population weight. As death rates are highly influenced by the deaths in the older age groups, to estimate the years of potential life lost due to premature deaths by a particular disease category, the years of life lost were calculated. And then we worked out age-standardized years of life lost rates in order to compare between populations. Moving to the results section, the graph shows male death rate in black, female death rate in yellow, and the overall death rate in red. As you can see, the overall crude death rate of Sri Lankan population has increased from 3.68 to 4.80 per thousand population over the period 1997 to 2014, which accounts for approximately 30% rise. Throughout this 17-year period, crude death rates of males was higher compared to that of females. Here the graph on the left-hand side shows the crude death rate for the 3 disease categories, whereas that on the right depicts standardized death rates. From 1997 to 2014, the leading cause of death was non-communicable diseases, followed by injuries and communicable diseases. If you look at the graph on the left-hand side, you can see that the death rate of non-communicable diseases has dramatically increased by 30%. In contrast, death rate from injuries was decreasing with peaks in 2005 and 2009 due to tsunami disaster and civil war, respectively. Decrease in pattern of communicable disease death rate was also evident, which could be attributed to improved postpartum care, better nutrition, effective vaccination programs, and elimination of malaria. Crude death rates of the three disease categories from 1997 to 2014 stratified by gender is shown in this graph. As you can see, the death rates of males in all three disease categories were higher compared to those of females throughout the study period. Crude death rates due to NCDs were increasing in both males and females. However, death rate of males due to NCDs was always much greater than that of females. Age-standardized death rate, age-standardized years of life last of all three disease categories from 1997 to 2014, stratified by gender, is shown here. This is the years of life lost in our population, standardized with WHO standard population. If you look at this, there is fluctuation of ASYR due to non-communicable diseases, unlike with crude death rate. This is because of the standardization procedure. Most of the NCD deaths occurred in older age groups, which have increased during the study period due to population aging. After the standardization procedure, Sri Lankan population under older age groups gets generalized. Standardized years of life lost of male NCDs has been greater than the total female ASYR from all three disease categories throughout the time period, except in 1997, 1998, and 2005. Male ASYR due to injuries clearly shows a decrease in trend over this time period, whereas that of female injuries remained steady, of course, except in 2005 and 2009. ASYR of communicable diseases in both genders were also quite stable throughout. NCDs accounted for the highest course of years of life lost in the entire period. If we take the single year 2014, when considering years of life lost for all the diseases, 60% of years of life were lost in males and around 40% were lost in females. Highest years of life lost had occurred in 60 to 64 years age group among males and 65 to 69 years age group among females. As you can see, highest years of life lost related to NCDs was also observed in 60 to 64 years age group in males and 65 to 69 year age groups in females. Highest years of life lost values due to communicable diseases was observed in infants in both genders. Significantly high values of preventable loss of lives due to injuries were seen for both males and females of working age group. Ladies and gentlemen, in conclusion, during the last 2 decades, the crude death rates of the Sri Lankan population showed a steady increase, with the NCD mortality in both males and females heavily contributing to this increase in pattern. Throughout the study period, age-standardized death rate due to NCDs in males was significantly higher than that of females. Death rates due to communicable diseases were dominant in infants, whereas death rates due to injuries were dominant in males of working age group. NCD death rate took the leading course starting from middle ages and continued throughout other age groups. The leading cause of preventable loss of life years was also NCDs, followed by injuries and communicable diseases. As there is an alarming rise of deaths due to NCDs among Sri Lankan adult population, as evident from this study, a paradigm shift in the structure of health system is timely and crucial. These are the references that we used. Thank you.
Thank you. Now the paper is open for the discussion. So how did you get the data?
We obtained data from the website of Department of Census and Statistics, Sri Lanka.
Okay. Right. In the absence of further questions, shall we proceed to the next paper?
Yeah. Next oral presentation is correlation between clinical diagnosis and spirometric classification among persistent visitors attending a tertiary care medical clinic in Central Province. The authors were Vijay Singh RPS, Rimza MRF, Ranavaka RND, Edrisingha CP, Basnayak BMS, Jayasingha IK, Yazaratna BMGD, and Anuttara GT. Welcome one of the authors for the presentation.
Good morning, everybody. I'm Dr. Vijay Singh. I'm going to present our study, correlation between clinical diagnosis and spirometric classification among persistent visitors attending to a tertiary care medical clinic. Going to background, bronchial asthma and chronic obstructive pulmonary diseases, COPD, are commonly diagnosed based on patients' symptomatology and signs in Sri Lanka. But spirometry is recommended by national guidelines. The facilities and technical support is not readily available for most clinicians. Our objective is to correlate the clinical diagnosis of asthma and COPD with spirometric results. When moving to methodology, we recruit a group of clinically diagnosed asthma and COPD patients who are attending to general medical clinics and VPOPD clinic in Teaching Hospital Peradeniya from July 2019 to February 2020. We did pre and post bronchodilator spirometry in all subjects. We used American Thoracic Society and European Respiratory Society standardization in spirometry 2019 update criteria for interpreting the spirometric results. When moving to results, we got clinically diagnosed bronchial asthma 228. From that, female 168 and 80 males, and COPD total 42 and 13 female and 29 male. When comparing with the spirometric results and bronchial asthma group, we got in asthmatic around 80% had either normal spirometry or reversible airway obstruction. This supports our clinical diagnosis of bronchial asthma. In this group, another 10%, around 10% had fixed airway obstruction, who represent advanced asthma or asthma COPD overlap. And interestingly, there were another 11% had mixed obstructive and restrictive pattern, those with asthma group. When comparing these spirometric results with among COPD group, 28 patients, that means around 67% had non-reversible airway obstruction. That was compatible to COPD. But 11 patients had normal 6 patients had normal spirometry, and 5% had reversible airway obstruction. This is not compatible with COPD clinical diagnosis. And interestingly, there were 7% had restrictive pattern that need further investigation. This is the comparison of spirometric diagnosis of asthma and COPD with after perform the spirometric diagnosis test. In our conclusion, 1/4 of clinically diagnosed COPD patients had normal spirometry or reversible air obstruction, warranting revisiting of diagnosis. Of clinical asthmatics, 1/10 had fixed airway obstruction, requiring treatment modification. Another 1/10 of asthmatics had mixed or restrictive pattern on spirometry, requiring further evaluation for additional restrictive lung pathology. Spirometry gives important insight to clinician in management of asthma and COPD. Thank you.
In this spirometric diagnosis of asthma, is it a challenge test, so you just they did just a spirometry? The asthma diagnosis is sometimes, not sometimes, it's based on the challenge test, gold standard. But
So-
this is just a address. They did a spirometry, is it?
No, we did actually we did inhaler errors, and same study we incorporate the spirometry to diagnose whether they are having asthma or COPD, and all together we got all patients, and we perform spirometry in all.
Other thing is there a difference in the duration of disease among the COPD, spirometric diagnosis of COPD and asthma? Because during long term, even asthmatics can become COPD like even on the spirometry or clinically. Was there a difference? Did you compare the duration of symptoms among patients with asthma on spirometry and patient with COPD on spirometry?
No, so actually we didn't do that.
Right.
These patients on inhalers from 3 months to 300 months. We got that sample.
Can I ask a question? When it comes to spirometry diagnosis, did you use only the spirometry or did you use the clinical criteria plus spirometry to diagnose COPD and asthma?
In generally clinic, we go with clinical diagnosis.
Yeah, I know
Yes,
that you are
spirometry is not
compared.
available. That, for this study, we did spirometry.
Right. So the interventional category or the second category you used only the spirometry. And of course you have
Already, they have already diagnosed as bronchial asthma or COPD, and from that we
did you use the new diagnostic criteria, the gold one?
no.
Right, thank you. Yes, we agree with your comment that in the new classification, spirometry is not considered as the gold standard in the diagnosis of COPD. It's a combination of clinical and spirometric data. But here what we looked at was whether there's any important thing that we are missing. Like especially there were a group of COPD people who are even reversible. So they need steroids rather than the bronchodilator. So that was the main aim of the study. And also there were a group with restrictive pathology who needed HRCT and other investigations to include a restrictive pathology. So yes, we agree with that comment. Gold standard is not now spirometry, but it's a combination of clinical and spirometric data. Thank you.
We move to the next presentation.
Right. The next presentation, the topic is carbimazole and radioactive iodine therapy outcome among hypothyroid patient, a prospective study. Authors are Sanos ARM, Nanakara DKK. Right.
Good morning, everyone. Our study title is carbimazole and radioactive iodine therapy outcome among hyperthyroid patients. It's a prospective study. You are aware that carbimazole is widely used antithyroid drug in Sri Lanka, and it inhibits the synthesis of thyroid hormone via several mechanisms. The inhibition of thyroid hormone synthesis is mainly responsible for the remission of disease. It mainly occurs in Graves' disease, and the induction of remission is very rare among toxic multinodular goiter patients. And only around 30 to 50% of the Graves' disease patients achieve remissions by carbimazole. But in comparison with carbimazole, radioactive iodine, it permanently destroys the thyroid gland, and it induces remissions or it controls the disease. And by using radioactive iodine, It helps to achieve rapid control of the thyrotoxicosis, and also it minimizes the adverse effects related to the carbimazole, because we will be using carbimazole for a longer duration, and the chances of adverse effects are high with carbimazole. By using a radioactive iodine, we minimize the chances of adverse effects of carbimazole. And also, due to the thyrotoxicosis, the patients can have more morbidity and mortality. So it also can be overcome by the usage of radioactive iodine. Our objective was to compare the therapeutic outcome between carbimazole and radioactive iodine among hyperthyroid patients. This prospective study was carried out at Nuclear Medicine Unit, Peradeniya, during the period of August 2018 to February 2020. A total of 89 patients were recruited for the study, and we followed up the patients for 6 months after radioactive iodine therapy at the interval of each 3 months. And we included patients with Graves' disease and toxic multinodular goiter, and patients with solitary nodule were excluded because they require larger doses of radioactive iodine therapy, and which could not be afforded at the nuclear medicine unit because of the outpatient setting. And the outcome of radioactive iodine therapy was determined at the end of 6 months from the delivery of the dose, and the euthyroidism and permanent hyperthyroidism were considered as therapeutic success. Persistent hyperthyroidism was considered as therapeutic failure. For the treatment outcome for carbimazole, we determined the euthyroid as therapeutically controlled and hyperthyroidism as therapeutically uncontrolled before providing the radioactive iodine therapy. Among our study group, there were a total of 67 patients having Graves' disease, which was around 75.3%, and there were 22 toxic multinodular goiter patients, which was around 24.7%. The overall study group has been treated for a mean duration of 3 years, which is more than 3 years, with carbimazole throughout their disease process. And with carbimazole, only 52.8%, which was 47 in number, were euthyroid after being treated for such a long duration, and roughly around 50%, which is 47.2%, were having persistent hyperthyroid. But after being treated with radioactive iodine, at the end of 6 months, the number of patients having therapeutic success, 75.3%, which is 67 patients, and only around 24.7%, 22 patients had persistent hyperthyroid. We compared these outcomes by the chi-square test, and the results showed that the patients who were treated with radioactive iodine, therapy had a better outcome. So this shows the outcomes. Therapeutic success has been seen in 75.3% of the radioactive iodine therapy, and also the number of therapeutic failure has been reduced after being treated with radioactive iodine therapy. So in conclusion, our study has found out that patients are being treated for a longer duration, unacceptable duration of carbimazole, despite a definitive treatment of radioactive iodine can be decided at early course of the disease. It can be either Graves' disease or toxic multinodular goiter, and the adverse effects related to the carbimazole can be minimized among these patients, and also the morbidities and mortality related to the thyrotoxicosis can be minimized among these patients. Thank you. These are our references. Thank you very much.
Right, the paper is open for the discussion. Can I ask a question? Now, what were the response rates? Did you find any significant difference in the response rate between Graves versus toxic multinodular goiter?
There was no difference in the etiologies, but in the overall population, it was significant. The Graves' disease and toxic multinodular had same response with radioactive iodine.
Yeah, what about the carbimazole?
Carbimazole also, there was no difference, but in toxic multinodular goiter patients, the carbimazole has been used for such a longer duration compared to Graves' disease. The response was the same.
Okay, that is a bit unusual, isn't it? Generally, the patients with Graves respond well to carbimazole, whereas toxic multinodular goiter, the response rate is poor. So in this study, of course, you couldn't find such difference.
It's true, because our patients are taking a high amount of dietary iodine, and it can affect the mechanism of carbimazole, and that can be a compound effect in the study.
Was there dose difference for the carbimazole given? What are the dose you have given?
Yeah, among toxic multinodular goiter patients, they required a high dose compared to the Graves' disease.
Any idea about the patient's acceptance about the treatment options, two different options?
Yeah, patients are less aware of the radioactive iodine therapy, and they have certain myths about the radioactive iodine therapy. So after educating them, they were ready to accept the radioactive iodine therapy.
So in the absence of further questions, we will move to the next one.
Next presentation is accuracy of 3 machine learning techniques to detect ischemic heart disease using electrocardiogram. The authors were Sudarka MDS, Abegurudvardhana IA, De Silva ESK, Abegunavardhana S.
Good morning, everyone. Accuracy of 3 machine learning techniques to detect ischemic heart disease using electrocardiogram. ECG. It's a widely available, inexpensive, and non-invasive test which is used in abundance to diagnose cardiac conditions such as ischemic heart disease, arrhythmia, and even non-cardiac conditions like electrolyte imbalances. Its interpretation is based on pattern recognition and usually done by skilled personnel. It has the potential for quantification like severity of ischemia. By that, it makes a good candidate for interpretation by machine learning techniques. What is machine learning? It is a form of artificial intelligence, and the name itself is self-explanatory. Machine learning, it's a machine that learns. I'll explain about traditional computer programming first. In traditional computer programming, you have to program every condition by code and writing the program. Then the computer runs the input through the computer program and then gives you the output. But in machine learning, you don't have to write the program. You just give some examples, a lot of it, examples for the machine learning model to learn from, and then machine learning model detects a pattern and write the algorithm or the program itself, and then when you give it the new data, it will give you the expected outcome. For example, in this case, we give a STEMI ECG with the label STEMI, and then tell the machine learning model that these features, like the amplitude of this ST segment, like these features will be important for you in getting your outcome. And then model detects the pattern and write the algorithm and gives you the outcome when you give another STEMI ECG that it is a STEMI. And the beauty of it, it learns as it goes. The more we use it, the more it learns and the better it becomes. Studies have been done earlier as well with coupling ECGs and machine learning techniques, but most of it had been done with arrhythmias, much less for myocardial infarctions. And when they have done it, they have only classified it as normal or abnormal, or just normal or arrhythmia. And the accuracies they have reached is around 85 to 90%. And the studies regarding myocardial infarction, coupled with their timing and territories, are very, very scarce. And our objective was to train machine learning models using medical knowledge to detect ischemic heart disease with respect to timing and affected territories with greater accuracy. We used 3 machine learning classification models, namely bootstrap aggregation decision trees, random forest, and multi-layer perceptron. And the data set we obtained was from Machine Learning Repository, University of California. They had 452 observations, 452 ECGs, and each had an assigned outcome. We removed ECGs that belonged to categories which did not have sufficient number of observations to train a machine learning model. We were left with 319 ECGs of 4 observation categories, namely normal, ischemic changes, old anterior myocardial infarctions, and old inferior myocardial infarctions. And each ECG had 279 features of all 12 leads, like P-wave, amplitude, P-wave duration. For all 12 leads, we had 279 features for one ECG, and we selected 73 out of that based on medical knowledge, based on the changes that are observed following a myocardial infarction. And then the data set was randomly split into a training set and a test set, and the 3 models were trained using the training data set. The models detected the pattern and built an algorithm to predict the outcome class. And then the test data was fed into the trained models, and then outcomes were evaluated. Overall accuracies for all 4 outcome classes, normal, ischemic changes, old anterior MI, old inferior MI, random forest model detected 91.67% accurately, and for bootstrap aggregation decision trees, it was 89.58. Multi-layer perceptron model, it was 85.42. And all 3 models correctly identified all changes of anterior MIs with 100% sensitivity and specificity. And random forest model also identified all inferior MIs with 100% sensitivity and specificity. When they identify all changes correctly, it improves the accuracy of acute changes and reduces the false positive rate. In conclusion, machine learning models can be used to interpret ECGs, and when you use medical knowledge for the machine learning techniques, you can improve the accuracy of it. And these models can be utilized in hospital settings to minimize the delays until trained personnel are available for ECG interpretation, and to alert the staff of a potential medical emergency, even in non-specialized primary care settings. This is not at all replacing the interpretation of physician's interpretation of ECG, but rather lending a more accurate helping hand to the untrained eye. And given a more expansive data set, or given a more extensive data set, we can expand this study to include more detail regarding timing and territories, as well as to detect arrhythmias. Thank you.
Thank you. The paper is open for the discussion.
Some of these are now available. ECG machine also gives a diagnosis at the end, possible anterior ischemia, possible anterior. That doesn't mean that those machines also have machine learning packages inserted?
No, sir. Sir, most of the time you may have observed that it is not correct. So those are deterministic algorithm-based models. Like I explained before, in traditional programming, you have to code each condition by condition. So that getting everything right is very difficult. So since it is coded by compute expert, not by medical personnel, it's very difficult to get everything right. So there you have to code everything code by code. But here, the machine learning model detects itself, even the complex association that is hard for the human mind to interpret. So this is much better than those ones. You may have clinically experienced it because those ECG interpretations they gave are not very much correct. But here it is.
For the comparison of the performance of 3 models, did you use same ECGs, or did you
Yes, it is the same, same 319 ECGs we fed for all these 3 models. Like I said, we randomly divided it into 70% and 30% of a training set and a test set. Then we fed the training set to all 3 models.
Right.
And then use the test set, which the models have not seen before, to evaluate this performance.
What about those differences? Significantly different or just non-significantly different?
It is significantly different, sir, but the performances are much better because individually their performances are different, but when we take it individually, their performances are much better than all 3 models' performances are much better than the existing deterministic algorithms.
Now, between the comparison between 3 models, those are significantly different or non-significantly different?
That was, we didn't compare the 3, but we just compared it with the existing one.
Okay.
So thank you. We are moving to the final presentation.
Thank you very much.
So last paper today, the topic is experience of NCD patients in healthcare delivery following sudden closure of Rural Healthcare Institute in Sri Lanka, a qualitative study. The paper will be, the authors are Vijay Singh RPS, Rimza MRF, Gavaraman IB, Silva LD, Hetiara CNM, Bandara AGJ, Paranagama AGM SKBA, Mubarak MHM.
Good morning again. I'm Dr. Vijay Singh. We are going to present our study on experience of NCD patients in healthcare delivery following sudden close of Rural Healthcare Institute, Sri Lanka, in Kandy district, a qualitative study. One of our district hospital in Central Points was suddenly closed nearly 1 year following public unrest. So patients seek medical care from other institute, and some patients were attended to teaching hospital Peradeniya. So our aim was to whether this group of patients satisfied with their health demand in view of NCD care, know the reasons to arise public unrest against this district hospital, and primary health care compliance in this group. Moving to methodology, this is a qualitative study carried out. Participants presented to outpatient department of teaching hospital Peradeniya following close of this district hospital. We use semi-structured in-depth interviews in 23 individuals, both in Sinhala and Tamil languages, recorded, transcribed, and data was analyzed thematically. Their referral. Referral means some doctors were referred, less than 50% referred, but more than 50% self-presented to teaching hospital Peradeniya. And according to our health bulletin, we have any health institute less than within 5 kilometers. They also had a health institute, another DH within 5 kilometers distance, but they were not treated there. In results, these patients, most are females, and around 80% of female, one third of patients without partners, and Tamil majority were there. It's around 80%, and more than 50% had family income less than 15,000 per month, and average distance to travel to teaching hospital Peradeniya is 17 kilometers, and average time 1.5 taken to reach teaching hospital Peradeniya. Most of patients, around 90% patients use public transport to come, and they most had to leave home before 6:30 a.m. to reach in teaching hospital Peradeniya. These are the diseases, most having around 20 patients out of 23 had hypertension, and diabetics is around 50%, and other diseases less, but 16 patients had more than 2 NCDs. They had problems when attending to teaching hospital Peradeniya. This is time, and they had to spend 7.8, nearly 8 hours in getting treatment from teaching hospital Peradeniya, and distance and traveling difficulties. They have to walk and use public transport as well, and money they have to spend for traveling, meals, and accompanying others. And positive points in DH clinic, it's near and easy to get care. They could go home early, and no extra expenses, no language problems there. Negative DH, there were no investigation, no laboratory facilities available, unavailability of drugs, depending on the officer in charge. Sometimes some officer of the officer in charge take medicine, all medicine, but some are not. The personal preferences are there to the patients, and they are not checked up regularly in clinics. And the clinic starts around 10 a.m. generally. It's late. Patient has to wait from 7 to 10 a.m. to consult a doctor. And those patients were most of the time scolded by staff at DH. The positive points at Teaching Hospital Peradeniya is, according to them, they got qualitative care with supportive staff and drug availability, investigation availability. We found some negative points in Teaching Hospital Peradeniya. They have to wait long time, and palm secure was a big problem, and some Tamils had especially language problem, and they found difficulties in finding places, labs, and other places when we require some investigation. Sometimes lab reports are lost, and these investigations every investigation are not done all days. We got some suggestions from health service development from them. They required the district hospital development. They required asked for establishing laboratory facilities and dispensing all drugs throughout the year. And Teaching Hospital Peradeniya, they asked for increase the number of doctors in clinic and arranging another pharmacy queue. When we asked whether they are willing to go back to this DH again, more than 50%, 57%, not willing. So we inquire why they are not willing to go to DH. Most patients were not happy with district hospital. They had feeling they were not treating well, and patients scolded, and drugs has to buy outside. Interestingly, few were happy of closing this DH. They think the quality of care is very poor, and they said if the DH is not closed, they were not able to come to Teaching Hospital Peradeniya. That patient got special attention by doctors, those who got blood testing on same day, morning, from the particular doctors. That clinic start to delay. When less number of doctors in the clinic, only prescription was issued and checkup is not done. Most of time blood pressure was checked on patient lay down in the clinic, not on all. And patient who had consulted other doctors and were ill-treated by some doctors. That's what happened. In conclusion, healthcare service delivery play major role in patient for attending to healthcare institute. Positive attitude of patient was selecting factor for their health demand. Patient willing to attend specialized center for NCD bypassing healthcare centers in this cohort. Thank you.
Now the paper is open for the discussion.
Now, we have seen these peripheral hospitals, they have a better documentation than the teaching hospitals. I must say, most of the hospitals, even I see in Katagostor and various places, they are well documented, their treatment patterns. Did you look at all those, were there any good documentation on this hospital? Did you look at their clinic follow-up books and all?
Yes, but it's not well documented. The 52% of patients had some difficulties with their treatment, and so they were improved either with reducing drugs or changing drugs in this group. So it was around one half of patient compliance is poor with this treatment from the district hospital. Documentation, they mainly repeated all drugs, and they have chances to refer them to specialized centers, but they were not.
Did you communicate back with them with the results?
Actually,
Did you communicate with their DM or whoever it is?
no,
with the
because
results?
of this hospital was closed, and the doctors moved out, and another set of doctors introduced.
Right, thank you.
Thanks.
So, with that, we conclude the free paper session. Thank you very much for participating in the free paper session.
Good morning. Good morning and welcome to all of you. Right. Now we are about to start our session, Grand Ward Round. Unravel the mystery. This is a new component in our SIMCON 2020. I'm Dr. Anuruddha Aryavansh from Peradeniya, and my colleague, the other moderator, is Dr. Aruna Kapilavansh. He is from Base Hospital, Diyathalawa. So, for next 45 minutes time, we have 3 medical cases to be discussed by very experienced consultant along with their registrars. So, in this ward round, so our registrars will present their cases to the consultant, and the consultants will discuss those cases in front of us as what we do in our general ward round. May I kindly invite Professor Anuja Premawardhana, Dr. Harsha Sachish Chandra, and Dr. Upul Disanaga to come up to the head table, please.
Good morning, everyone. We will start with the first case for the Grand Ward Round today. This case will be discussed by Professor Anuja Premawardhana. He is currently working as a senior professor in medicine in University of Kelaniya, Sri Lanka. He is a specialist physician in internal medicine and has a research interest in hemoglobinopathies and iron metabolism. He is also the founder and current consultant in charge of the Adolescent and Adult Thalassemia Center and Laboratories attached to the North Colombo Teaching Hospital, Ragama. He has over 100 research papers and published abstracts in indexed journals, and in 2020 has an H index of 20. Now his registrar, Dr. Manod Pabasara, has joined us virtually to present the first case. May I invite Dr. Manod to proceed with the case.
Good morning to all of you, ladies and gentlemen. Welcome to the Grand Ward Round. I hope you can hear me. Today, our discussion is based on changing phenotypes in thalassemia patients. And it will be based on 3 patients. Patient number 1 is Miss F, a 29-year-old diagnosed patient with beta thalassemia major, who is on regular blood transfusion since the age of 18 months, who has underwent splenectomy at the age of 12 years. She had a complicated clinical cause with late puberty, for which she was started on hormone replacement therapy at the age of 17 years and also developed diabetes at the age of 22. Well, to maintain a serum ferritin value of less than 500 nanograms per milliliter. But from 2017 August onwards, her transfusion requirement began to increase, needing frequent transfusion from once in every 6 weeks to once a week within just 12 months. And also she needed more than 5 to 6 units to maintain her pre-transfusion hemoglobin of 8 grams per deciliter. Even though we have intensified her chelation to dual chelators with maximum doses, her serum ferritin value kept rising, and finally, it was more than 10,000 nanograms per milliliter. Unfortunately, in October 2019, so the question here is, why did her transfusion frequency increase so dramatically? Patient 2 is Miss T, a 17-year-old girl with beta thalassemia major who is on monthly blood transfusion since the diagnosis, and she was well chelated from the beginning and has not undergone splenectomy. She attained menarche at the age of 11 years with normal growth and development without any endocrine issues and had a mild splenomegaly of 1 centimeter. But she usually needed 2 units of blood transfusions in every 5 to 6 weeks, but over last 2 years duration, her transfusion frequency increased dramatically, needing 4 units once in every 2 to 3 weeks, and still her pre-transfusion hemoglobin dropped to 5 grams per deciliter within just 2 weeks. So again, why did her transfusion frequency increase rapidly? Our third patient is Mr. N, a 44-year-old male who presented to hospital in Qatar 12 years ago with shortness of breath, where he was detected to have anemia with a hemoglobin of 6.8. He was transfused 2 units of blood, which improved his symptoms, though the cause for anemia was not investigated. And he worked for 8 more months without needing further blood transfusions. Again, in Sri Lanka, he was detected to have severe anemia with hepatosplenomegaly with a spleen of 5 centimeters. And his HPLC showed a HbA2 of 5.4%, which is characteristic of beta thalassemia trait. And further genetic studies revealed he also had 6 alpha genes, and the diagnosis of thalassemia intermedia was made. He was advised to keep his hemoglobin around 7 to 7.5 grams per deciliter and had a quite uneventful life for many years. But with time, things began to change for him too. His transfusion frequency increases rapidly, needing transfusions once in every 2 weeks, ultimately being massively transfusion dependent. And on examination, he had hepatosplenomegaly with a spleen of 8 centimeters and transfusion requirement of 350 ml per kg per year. Then he became severely iron overloaded and developed complications like chronic liver disease, pyelonephritis, and succumbed during the last episode in April 2020 with septicemia and heart failure. So again, the question is, why did his transfusion requirement increase dramatically? Over to you.
Thank you, Babasara. So this scenario is essentially of 3 patients with thalassemia, 2 with thalassemia major and 1 with thalassemia intermedia, who had stable phenotypes who became unstable midway through their lives. The question is, what really happened? The first one was a beta thalassemia major who had been poorly managed in childhood, who needed splenectomy and had developed iron overload features in childhood, who managed to chelate herself out of it only to become heavily transfusion dependent and heavily fatally iron overloaded midway through her life. The second, a young girl, very different from the first one, very well managed at the beginning with very well chelated as well, no complications, but suddenly becoming massively transfusion dependent and iron overloaded. The third is a thalassemia intermedia young man who had been not on any transfusions at all, and at about the age of about 24 becomes massively transfusion dependent, iron overloaded, fatally so, and his spleen enlarges from 5 centimeters to 8 centimeters, but during this phase, his transfusion requirement increases to a shocking 350 milliliters per kilogram per year. Now, when you deal with something like this, the possible explanations might be hypersplenism, development of a second hemolytic anemia over and above what happens in thalassemia, like an immune-mediated hemolysis, or a completely unrelated disorder. Now, when you assess the case of the spleen, the first 2 patients, it's very unlikely to have been due to hypersplenism because the first one didn't have a spleen and the second girl had a very small spleen. In the case of the third patient with intermedia, the spleen increased only from 5 centimeters to 8 centimeters, Is it possible for somebody like that to develop hypersplenism? We examined the blood counts of this man, and we found that towards the latter part of his life, he had persistent pancytopenia. And to look for an explanation for this, we did a bone marrow biopsy, but found nothing other than features suggestive of peripheral destruction. There was no features of development of antibody formation because the cross-match and compatibilities was normal. And in a sense, there was no other explanation besides hypersplenism which could explain this excessive blood consumption in him. So he needed treatment for hypersplenism, essentially splenectomy. But splenectomy is associated with very significant dangers in thalassemic patients, notably severe infections. Infections is the commonest cause of death in patients with thalassemia, particularly in the tropical countries. And since of late, there's a body of evidence which suggests that there's an increased risk of thrombosis, particularly venous thrombosis. On top of this, there's evidence to suggest the development of pulmonary hypertension in splenectomized thalassaemic patients. With this body of evidence, the tendency to splenectomize thalassaemic patients is now going away. We try to preserve the spleen by hypertransfusing them or by giving drugs like hydroxyurea. And that's exactly what we did this patient. Avoided splenectomy by hypertransfusing him and gave drugs like hydroxyurea. And by doing that, I think we killed him. And so in situations like this, even though splenectomy may be dangerous, there is a definite time where splenectomy may be necessary. In children who fail to grow, in situations where transfusions cannot be met up with or chelation cannot be kept up with, like in our patient, where pancytopenia becomes symptomatic, like bleeding due to thrombocytopenia, or where the spleen is so large that it causes symptoms. But infections in splenectomized patients is a very real risk. And if you get a fever in a splenectomized thalassemic, it has to be very aggressively investigated and treated. To prevent infections, we vaccinate them with pneumococcal every 5 years, influenza every year, Haemophilus and meningococcal once in their lifetime. And we start on them with prophylactic antibiotics for life, but none of that prevents infections absolutely. There is a very serious risk of venous thromboembolism, particularly of the mesenteric, portal, and the splenic veins. And this risk is particularly high if you splenectomize people for thalassemia and also for hematological cancers. Unfortunately, there's no guideline on how to prevent this. Now, moving to the other two patients, hypersplenism is clearly not the reason. Is it possible that they develop immune-mediated hemolysis? Now, naturally occurring antibodies to red cells, the only naturally occurring antibodies are the anti-A and the anti-B. Any other antibodies against the red cells are alien antibodies. There are two such antibodies which can form. Antibodies against foreign antigens, which are called alloantibodies, antibodies against your own antigens, which are called autoantibodies. Alloimmunization is a natural process which occurs in pregnancy. But alloimmunization in multiply transfused patients and intra-organ transplantation is a real headache. Now, in the red cell system, besides the ABO system, there are 35 other red cell antigens against which antibodies can form. This includes the rhesus, MNS, KEL, LUI, and many, many other more. Now, in multiply transfused thalassemia patients, alloantibodies are known to occur in 5 to 30% of patients across the world. In Asian thalassemics, the rate of alloimmunization is thought to be about 22%. Alloantibodies occur mostly in thalassemics who are older, who have been splenectomized, who have been started on transfusions later in life, like in the thalassemia intermedia as opposed to thalassemia major patients. Alloantibodies are usually silent and very often at worst cause delayed transfusion reactions. But they are a real headache for the transfusion physicians because you have to find perfectly matched blood for transfusions. It's a very different kettle of fish, these autoantibodies. And autoantibodies occur in about 6% of multiply transfused thalassemic patients. They too occur in splenectomized thalassemic patients, and autoantibodies usually coexist in patients who have alloantibodies. Unlike the alloantibodies, they cause vicious hemolytic reactions. And in our patients, both of them had clear evidence of autoimmune hemolytic anemia. In the case of the first patient, she only had autoimmune hemolytic anemia. The second patient also had evidence of alloantibodies. Both had evidence of warm antibody, autoimmune hemolytic anemia. There was no ANA, no dsDNA, so the only reason for the autoimmunity was probably the multiple transfusions. And these are very difficult conditions to treat, as we found it ourselves. Ms. F passed away despite very high doses of steroids and azathioprine. We are struggling to treat Ms. T. She is failing to respond even to rituximab. So the only way is to prevent formation of antibodies. To do that, we phenotype, red cell phenotype, all thalassaemic patients before they are put on the first transfusion. The ideal way is to give all thalassaemic patients leukodepleted blood, cross-match for ABO, rhesus, and KEL. This is a very trying thing to ask from the already stressed out transfusion systems. Thank you very much.
Thank you very much, Professor Noje. Since we have 2 minutes, we can allow one question.
Yes, only problem is it is a temporary measure. So plasmapheresis IVIG can also be used, but because it is not going to go away. So for example, the only surviving patient, Ms. T, she's failing to respond to rituximab. Right now we are considering cyclosporine. In an emergency scenario, we can use plasmapheresis and give IVIG, but it's a short-term thing. The issue is how are we going to keep her going?
Thank you very much, sir. I think we are running out of time. So let us move to the next case discussion. It is from National Hospital, Colombo. Dr. Harsha Satish Chandra. Dr. Satish Chandra, MBBS, MD, MRCP, FCCP, is a specialist physician in internal medicine at National Hospital, Sri Lanka. He graduated from the Faculty of Medicine, University of Colombo in 1994 and obtained his MD, Medicine, University of Colombo in 2000. He did his overseas training at the University of Cayley Hospital in the UK from 2002 to 2004, and he was awarded MRCP in 2003. He was a council member of the Ceylon College of Physicians in 2009 and 2010. He is the president-elect of the Sri Lanka College of Internal Medicine. So his registrar, Dr. Pasan Abe Senevi, will present the case. Please come up to the podium, Dr. Pasan.
Good morning, dear esteemed guests. Good morning, sir. Today I thought of presenting a young patient who presented with visual loss. So if I move on. This is Mr. C, a 38-year-old previously unscreened male from Panipitiya, who was transferred from the National Eye Hospital, where he had presented complaining of progressive loss of vision over 2 weeks. There had been acute worsening of this vision over the last day, with only retaining of perception of movements. With this history, he did not complain of headache. There was no weakness or numbness. There were no seizures. There was no early morning vomiting. He had also noticed that he had a mild reduction of the urine output during the last week, where there had also been a mild painless hematuria for 2 days, but it had settled on its own. There was no dysuria or any other lower urinary tract symptoms, and there was no froth in urine. There was also a reduction in his exercise tolerance, but there was no cough, sore throat, no orthopnea or paroxysmal nocturnal dyspnea. There was no chest pain or palpitations. There was no abdominal pain. And he denied a history of fever or loose stools. And there was no easy bruising or an associated history of loss of weight or loss of appetite. He also did not have a history of any arthralgia, ulcers, rashes, and there was no childhood history of recurrent UTI or any other renal problems. He was a smoker and consumed alcohol occasionally, but there was no other history of any non-communicable diseases, and there was no past history of TB or any malignancies. And he did not have a history of any drug abuse or blood transfusions. Further on, the past surgical, allergies, and the family history were all unremarkable. Moving on to the social history, he was unmarried, had studied up to A levels, and lives with his parents. The main problem here was that he was worried about the outcome of this because he was working at a media company as a model. So therefore, the impact it would have on his life, which made him worried about. Moving on to the examination, he was afebrile, well-built. There was severe pallor, but he was anicteric with mild ankle edema. As I said before, there were no skin rashes or petechiae and no ulcers. Cardiovascular system examination revealed that there was quite a high blood pressure. It was more than 200, but a regular pulse rate with good volume and tachycardia. No murmurs, and the cardiac apex was not shifted. There was no third heart sound. Respiratory system examination revealed bibasal crepitations bilaterally, but otherwise the saturation maintained with no dyspnea initially. Abdominal examination was unremarkable with no free fluid being present. Fundoscopy revealed grade 4 hypertensive retinopathy with macular edema, and there were bilateral retinal detachment, and there was only perception of movements. Visual acuity was severely affected. Otherwise, cranial nerve examination and limb examination were all normal.
I think, Pasan, you got quite a few abnormalities in the history and examination. Can you just give the salient features, what you picked up?
Yeah. The salient features were that the patient presented with progressive visual loss which had worsened within 1 day. And he had also noticed a reduction of the urine outputs, which also was associated with a mild episode of hematuria, which had settled. And there were also signs of anemia. Again, bilateral ankle edema was there with uncontrolled hypertension and bibasal crepitations. And the fact that there was a grade 4 hypertensive retinopathy with macular edema and retinal detachment. These, I think, are the salient features of this presentation.
Yeah, so it seems that the patient has had some neurological manifestations, mainly visual loss, and severe anemia seems to be an issue. And also, I think there were signs of fluid overload.
Yes.
With very high blood pressure. So let us try to see what DDs we have to consider in this scenario. With this degree of hypertension and signs of fluid overload, I think we have to consider malignant hypertension with renal impairment as our first DD. It could also be acute nephritic syndrome with a glomerular pathology. he had neurological manifestations, and there was visual loss, and there was renal failure. So I think we have to consider thrombocytopenic purpura and a hemolytic uremic syndrome. In this situation, there was no diarrhea associated. Normally, with the Shiga toxin-induced hemolytic syndrome, there is diarrhea associated. So this will probably be an atypical type of hemolytic uremic syndrome. So I think those are the things that we have to consider. Yeah, shall we proceed?
Yes, sir. Proceeding on to the investigations
Yeah, it's a bit of a crowded slide, but I think the main things are he has very severe anemia, hemoglobin of 5.3 on presentation,
yes,
and maybe a moderate degree of thrombocytopenia. Serum creatinine is very high, 18.4 milligram per deciliter, and I think the other main thing is high LDH. Any other investigations?
Yes, sir. INR and APTT were not deranged. And as we expected, blood urea was quite high. Troponins were negative, along with the ESR being normal. And the other thing was that the albumin was quite reduced, with the ECG being suggestive of hypertensive heart disease with lateral changes.
So the normal clotting profile is of significance, and also I think the ECG the changes in the ECG suggest to us that this probably is chronic hypertension. Any other investigations?
Yes.
Yes, I mean that blood picture, I think it shows definite evidence of microangiopathic hemolytic anemia. Can see the platelets are very few in number, and schistocytes are also there. So that's, I think, quite definite evidence of microangiopathic hemolytic anemia. What did the hematologist report it as? I think said that it's in favor of TTP. I'm not so sure whether we can come to that diagnosis based on this blood picture.
Yes.
So we probably need more information. Yeah, can we proceed? Yeah.
Yes, if you look at the UFR, there was albuminuria with pus cells of around 2 to 4, and the other salient finding was that it was moderately full of red cells. Culture didn't show any growth. Calcium level was on the low side with phosphates being high.
Yeah, again, I think lots of investigations here. Yeah, carry on.
Yeah, if we talk about the UPCR, it was actually subnephrotic range with urine dysmorphic red cells not being present. And the ultrasound KUB was suggestive of AKI on CKD with no other background infections.
Yeah, can you summarize those and give the striking features in the investigations, because quite a few abnormalities were there?
Yes, we went ahead with doing the echocardiogram as well at the initial presentation, which was again confirming the possibility of a chronic hypertensive heart disease. Chest X-ray was showing a left-sided pleural effusion. NCCT brain was almost normal, and the renal arterial duplex scan did not show any features of renal artery stenosis. So again, if I move on, talk about the striking abnormalities here, there was severe anemia with thrombocytopenia, and the coagulation studies were normal along with these. There was proteinuria with microscopic hematuria along with it was subnephrotic range. And the serum creatinines were very high with high LDH levels, suggestive of hemolysis, again confirmed with the blood picture where MAHA was present. And as I said before, ECG and the echocardiogram confirmed the hypertensive.
Yeah, let's try to give a DD for this, and because we have to proceed with management. Yeah, I think now from our original DD, I think malignant hypertension of some due to some etiology leading to severe renal impairment, and thrombotic microangiopathy should be our first DD. thrombotic thrombocytopenic purpura we've got to consider, but the degree of renal failure is probably against that. Again, atypical hemolytic uremic syndrome is possible because of the severe renal impairment and the thrombotic and the microangiopathy. Now, if we proceed, now the common thread here is that there is thrombotic microangiopathy. Now, the cause is not very clear. Could it be due to malignant hypertension causing a secondary thrombotic microangiopathy, or could it be a primary disorder like TTP or atypical hemolytic uremic syndrome? Now, why is the distinction important? Because if it is like TTP or HUS, we have to go ahead with plasma exchange. But if it is due to malignant hypertension, probably supportive therapy might clear it up. But I think we can't take a chance. I would initiate plasma exchange. What did you do, Pasan?
Yes, actually, we initially tried our best to get the blood pressures down gradually. We even had to use IV G10 infusions and labetalol as well. And we went ahead with a nephrology referral where they wanted to initiate dialysis. While dialyzing the patient, with the opinion of the hematology team, we went ahead with plasma exchange after referring the patient to a transfusion specialist at NHSL. So 5 cycles of plasma exchange was actually done, sir.
Okay. So did you do any other investigation? Quickly give the positive, any positive things you found?
Actually, sir, the autoimmune studies were all normal with also hepatitis being negative. HbA1c again was normal with high ferritin levels. Otherwise, there was nothing much identified with further investigations. We went ahead with the renal biopsy where it showed mesangial matrix proliferation, but the most salient finding was that there was fibrointimal thickening of blood vessels.
Yeah, so I think the biopsy is in favor of microangiopathy. So we have actually histologically shown that there was thrombotic microangiopathy. There is no evidence of glomerular disease. Immune staining was normal. So I think the issues here, now the final diagnosis, I think, I suppose we can say that was probably due to malignant hypertension causing thrombotic microangiopathy and renal failure. Of course, here the visual signs. And renal biopsy confirmed the findings. Of course, the workup for the secondary hypertension is in progress at the moment. So this case, and I suppose I think we proceeded on the normal management pathway you highlighted. So the issues here in this case was, can you proceed, Prasan? Yeah, I mean, if we reflect on this case, now we had an issue because there was thrombotic microangiopathy that could be diagnosed clinically and with the basic investigations, but we were not sure it was malignant hypertension causing that or whether it was a primary disorder. Now, we had the drawback of not having access to an Adams 13 level. If that was low, that would have shown that it was TTP. And, but we didn't have access to that. Overall, we had to make some clinical decisions, and the role of the internist here was highlighted because there were several issues that needed a management decision. And I think it's the role that the internist plays is central here, especially in a background of limited resources where you have to make clinical decisions to make the patient safe. I think that's what I would say that we have to learn from this case.
Yes. Thank you.
Now we will move to the last case of this session, again from National Hospital, Colombo. This case will be discussed by Dr. Upul Dishanayake. Dr. Dishanayake, MBBS, MD, FCCP, FRCP, is a consultant physician attached to National Hospital of Sri Lanka. He graduated from the Faculty of Medicine, University of Colombo in 1992. Dr. Dishanayake obtained his MD in year 2000 and board certified as a consultant physician in 2002. He is a past council member of Sri Lanka College of Internal Medicine. He is a postgraduate trainer and an examiner for the PGI. May I invite his registrar, Dr. Vasundhara, to come to the podium to present the case.
Good morning, everybody. Today, our patient is a 33-year-old, previously well, a mother of one child, a housewife from a provincial capital. She presented to us with unintentional weight loss over 6 months duration. Her weight was 75 kilograms in last January, and it has dropped to 30 kilograms by July. So there was 60% weight loss over 6 months period. These are her images. First image was taken in January and the second image was taken in July after admission.
Vasundhara, how do you broadly categorize the patients with weight loss?
We can categorize patients with weight loss into two main categories. One is weight loss associated with loss of appetite. The other one is loss of weight with normal or increased appetite. Interestingly, our patient did not have any loss of appetite. Actually, she was hungry all the time and she wanted to eat.
What are the causes for loss of weight without loss of appetite?
Loss of weight with loss of appetite occur mainly in endocrine diseases such as hyperthyroidism, uncontrolled diabetes mellitus, and Addison's disease. Also, certain malabsorption syndromes which can present without constitutional symptoms like celiac disease should be considered.
Did she have features of any of them?
In my history and examination, I didn't find any features to suggest these diseases. In her investigations also, her thyroid function test, 9-AM serum cortisol, fasting blood sugar and HbA1c levels were normal. And she did not have any history of chronic diarrhea or steatorrhea suggestive of malabsorption syndromes. And apart from fatigability, lethargy and malaise, which may be features of anemia, she did not have any features to suggest osteomalacia or increased bleeding tendency to suggest malabsorption of fat-soluble vitamins. We will be discussing about further investigations later.
Okay, what were the other significant symptoms did she have?
She complained of an unusual cough which lasted for about 8 months, and it has started before she noticed any loss of weight. This cough occurs mainly while eating and there's no cough at other times. This cough starts as soon as food entered her mouth, even before initiate swallowing. And sometimes this cough goes on for minutes and results in vomiting.
Okay, what are the causes for loss of weight with cough?
Loss of weight and cough occur mainly in conditions like tuberculosis and also carcinoma of lung. However, cough does not occur in association with eating in these conditions. But because of high prevalence of tuberculosis and in order to exclude sinister causes, we carried out following investigations. Her ESR was 88 millimeters per hour, whereas CRP was only 20, and her chest X-ray was normal, MAN2 was negative, sputum gene expert, quantiferon TB gold tests were negative. Also, the CCT chest was normal, and CCT abdomen revealed hepatomegaly with fatty infiltration and mild splenomegaly. Clinically, she did not have hepatosplenomegaly.
What are the conditions where somebody gets cough as soon as she starts eating?
Well, this can happen in any anatomical, physiological or neurological problems in the process of swallowing. However, neurological causes usually cause difficulty in swallowing more for liquids rather than the solids. And in my examination also, I didn't find any cranial nerve palsy or bulbar palsy, and there were no episodes of aspiration pneumonia. For further evaluation of these causes, we carried out following investigations. Her upper GI endoscopy, barium swallow were normal and did not reveal any structural abnormality. Also, esophageal manometry was normal and did not reveal any esophageal dysmotility or problems in esophageal sphincters. And the fiber optic laryngoscopy and fiber optic endoscopic evaluation of swallowing test were normal and did not reveal any problem with her swallowing.
Do you know any conditions where the people start coughing and vomiting immediately after taking food?
In that situation, we thought of possibility of anorexia nervosa. However, she did not have any evidence of distorted perception of body image. There was no self-induced vomiting or diuretic or laxative abuse. Interestingly, she was so worried about her weight loss, whereas patients with anorexia nervosa usually do not complain of loss of weight.
How do you demonstrate a distorted perception of body image?
We can ask person to draw herself, and if a thin person draw herself as a fat person, there is distorted perception of body image.
What was her nutritional intake like?
She used to take 3 main meals and 2 snacks per day. Because of this cough which starts as soon as she starts to eat, she could not eat well at each meal. She had to stop eating after taking 2 to 3 mouthfuls. Because of that, there was severely reduced calorie intake, and according to 24-hour dietary recall, her calorie intake was 500 kilocalories per day, which is 30 to 40% of recommended daily allowance. And she is a non-vegetarian. Because there is no cough with liquid food, she preferred to take dairy products. However, she could not afford due to poor economic status.
Okay. Other than the weight loss, did she have any consequences of poor nutritional intake?
She had alopecia, which can be due to malnutrition. Also, it can occur in any form of weight loss, severe stress, or any illness. She had non-scarring alopecia, which is usually a feature of SLE. And in her investigations, she had anemia, but it was normochromic normocytic anemia. Her serum iron studies initially were normal, later revealed iron deficiency. Total calcium, phosphorus and vitamin B12 levels were normal. Vitamin D level was insufficient.
Okay. Having excluded the common causes for loss of weight, did you consider any other diagnosis?
Yes, although loss of weight is not a common presenting feature of connective tissue disease, we considered connective tissue diseases like SLE, rheumatoid arthritis and systemic sclerosis. Apart from alopecia, she did not have any oral ulcers, skin rash, photosensitivity to suggest SLE, and no arthritis, no history of Raynaud phenomenon or skin thickening to suggest systemic sclerosis. Her full blood count revealed leukopenia without neutropenia, and her ANA was positive with a titer of more than 1 in 80. Anti-dsDNA antibodies were positive, and complements both C3 and C4 were low. Rheumatoid factor and anti-SCL70 antibodies were negative.
Did she fulfill the criteria for the diagnosis of SLE?
Yes, she did. According to the 2019 ACR-EULA classification criteria, she had the entry criterion, that is positive ANA with a titer of more than 1 in 80, and she had leukopenia and non-scarring alopecia as the clinical criteria, for which she scored 5 marks, and positive anti-dsDNA antibodies and low complements as immunological criteria, which she scored 10 marks. Altogether, she scored 15 marks and therefore can be classified as having SLE. However, she did not have typical mucocutaneous features or neuropsychiatric manifestations or renal involvement of SLE.
Okay. Now we have diagnosed SLE. Are you happy to label her loss of weight and cough as due to SLE?
Weight loss is common in SLE, but generally the extent of weight loss in SLE is about less than 10% from the baseline. Our patient, 60% weight loss, we can't explain with SLE alone. And also she has this unusual cough which cannot be explained with SLE alone. As I described above, this cough starts as soon as food touches her mouth before initiate swallowing. It's a feature of oropharyngeal dysphagia, where there is difficulty in transferring food from mouth to pharynx. This is in contrast to esophageal dysphagia, where the symptoms occur few seconds after patient initiates swallowing and there is sensation of food stuck at throat or chest, which our patient did not have. When we consider the causes for oropharyngeal dysphagia, it can be structural lesions of the oropharynx, abnormal upper esophageal sphincter, neurological causes, systemic sclerosis, salivary hypofunction. By now, with history, examination and investigations, we have excluded almost all of these causes except the salivary hypofunction due to Sjogren syndrome. Decreased salivary production can lead to adherence of food into the buccal mucosa, causing coughing and choking while eating dry solid food there's no difficulty in taking liquid food. In addition to that, it can cause dental caries. Our patient also had dental caries. However, she denied dry mouth, dry eyes or dyspareunia. In order to further evaluate for Sjogren syndrome, we carried out Schirmer's test, which was positive in bilateral eyes, and also labial gland biopsy, which revealed focal lymphocytic sialadenitis. And her ENA panel revealed positive anti-Rho antibodies. According to the 2016 ACR EULA classification criteria, with positive labial gland biopsy, anti-Rho antibodies, and positive Schirmer's test, she scored 7 marks. Therefore, she can be diagnosed as having Sjogren syndrome. So, we made a diagnosis of SLE with secondary Sjogren syndrome. Cause for her excessive weight loss was reduced calorie intake due to difficulty in chewing and deglutition of solid food as a complication of Sjogren syndrome in the background of SLE cachexia syndrome.
How did you treat her?
We started her on nutrition rehabilitation, gradually increased her calorie intake to 1400 kilocalories per day. We did this with liquid food and blenderized food, and rheumatology was done, and she was started on hydroxychloroquine and prednisolone for the treatment of SLE. At the same time, she was started on artificial tears and artificial saliva. Also, she was taught about basic measures to prevent oral dryness. With these measures, she could gain 8 kg of weight after 1 month of treatment. Thank you.
Thank you, Vasundhara. This case highlighted the importance of taking a very good history. Now, though we came to diagnosis within the last 12 minutes, it took about 1 month for us to arrive at this diagnosis. If we took the history very clearly about the cough, the way that the cough started, we would not have done most of the investigations and would have come to a diagnosis much earlier. Therefore, the history is of paramount importance in a patient with the illness. Thanks.
Thank you very much, sir. I think we are just running out of time, so I'm afraid that we don't have any extra time for question and answers. So let me thank Professor Anuja Premardana, Dr. Satish Chandra, and Dr. Uful Disanayake, and their registrar for this nice case discussion that gives some insight about what is happening in our medical wards and the range of medical cases that we discuss and we identify in our general medical ward rounds. So it is now time to deliver the letter of certificate of appreciation. So let me invite Dr. Aruna Kapilawansa to deliver certificates. Professor Anuja Premawardhana. And Dr. Manoj, he is not physically present here, so I think we will hand over to Professor. Thank you, sir. Dr. Harsha Satish Chandra. Dr. Upul Disanaike. Let me call upon Dr. Pasan Abesenevi. And Dr. Vasundhara Vathura Patha. Thank you very much, everybody, to be present here for this excellent discussion. Thank you.
Good morning. Good morning, all of you, for the first symposium of the day, Heart Failure, What's New. We have four important topics that are going to be discussed today, and we have four eminent speakers joining us, one in person and three virtually. Let me invite Dr. Vasantha Disanayake to come to the stage if he's around. Right. So, for the speakers, each speaker will get 20 minutes for the presentation, followed by 10 minutes for the discussion. So at the end of the 10 minutes, we will get question in person as well as virtually. And with that, I would invite the first speaker to deliver the talk, which is on introduction of heart failure. I would invite Dr. Vasantha Disanayake. Dr. Vasantha Disanayake is one of the consultant physicians attached to National Hospital Kandy. He is going to talk to us an introduction to heart failure. Thank you.
Good morning, everyone. So, heart failure is a very important topic. You will realize it's an important topic for the internal medicine physicians. I don't have any conflict of interest in my presentation and nothing to declare. I have shared some slides from American College of Physicians lecture series last year, except that I don't have anything to declare. Heart failure is a high-cost, complex, chronic conditions with high readmission rate and poor clinical outcomes. Very important to understand. So management has been changed during last 10-15 years according to new research findings. So I am going to, just to introduction, I am going to discuss topics, few scope of the problems, classification, etiology, and clinical presentation and diagnosis. I don't have any much statistics in Sri Lanka, so I thought the world statistics. If you look at the American statistics in 6.5 million American adults have heart failure. And if you look at the annual new increase events per 1,000 persons per year, it is increasing every year. So in USA itself, 1 million new cases of heart failure are diagnosed annually. So vast majority of those patients are diagnosed 65 years or old. So you can see this diagram over 85 years is very common. heart failure. Heart failure is the leading cause of hospitalization, morbidity, mortality in older adults. So risk factors, to look at the sex and age, as I told you at the beginning, with age, the heart failure incidence is going up. And with age, the female has more preponderance than the male. If you look at the heart failure in patient diabetics or 30-year follow-up in Framingham study, you will see these slides. The cardiac failure is one of the commonest complications of diabetes when you become old. And it's very common in women than men. So lifetime risk of heart failure, indeed, the blood pressure, and if you look at, again, when the pressure is high, the risk of heart failure is very high. And even every citizens, one person, every fourth citizen, one person will get heart failure in their lifetime. So we are very high risk of getting heart failure when we become old. And higher the blood pressure, higher the chance of getting heart failure. So diagnosis of heart failure in old adults more often challenging is due to multimorbidity, polypharmacy, cognitive impairment, and frailty. I think you have listened to yesterday's lectures, and frailty they have discussed in lengthy. So these are the 4 factors which cause challenging in the diagnosis of heart failure. And classical symptoms of heart failure, fatigue, dyspnea, reduced exercise tolerance are common among old adults and frequently overlooked. You won't get sometimes typical symptoms of heart failure in old adults, and the most often relations or the parents, relations or the children, they neglect because this is the normal thing for your age, like that. So there's a high chance they will miss their diagnosis of heart failure. So you can classify into A, B, C, D stages. Stage is presence of heart disease, risk factors, but no disease, no symptoms. And stage B is heart disease is present, but there's no symptoms. But there are structural heart disease in the maybe diastolic heart failure, sometimes left ventricular hypertrophy. Stage C is structural heart disease and symptoms. Stage D is advanced heart disease, continuous heart failure symptoms requiring medical therapy. Because these are important when you understand guideline in next few lectures in management. And New York Heart Association classifies as class 1, 2, 3, 4. One is no limitation of physical activity. Ordinary physical activity does not cause undue fatigue, palpitation, dyspnea. And class 2 is slight limitation of physical activity, comfortable at rest, but ordinary physical activities are in fatigue, palpitation, and dyspnea. Class 3 is marked limitation of physical activity, comfortable at rest, but less than ordinary activity cause fatigue, palpitation, and dyspnea. Stage 4, class 4 is the unable to carry out any physical activity without discomfort. Symptoms of cardiac insufficiency at rest. If any physical activity is undertaken, discomfort is increased. So classification now classify ejection according to ejection fraction. Ejection fraction less than 40 or more than 50. Less than 40 called heart failure of reduced ejection fraction or HREF. Over 50 called HPEF or ejection fraction with preserved ejection fraction. Reduced ejection fraction is all known as hysteric heart failure in the past, and RCCD have mainly enrolled reduced ejection fraction patient. Only these patients have efficacious therapies being demonstrated. So this is most of the studies done on reduced ejection fraction. Preserved ejection fraction also known as diastolic heart failure. Diagnosis challenging because largely in all excluding potential non-cardiac causes of symptoms suggestive of heart failure. No efficacious therapies have been identified. And then there's a group between 41 and 49, where intermediate group, characteristic treatment pattern and outcome appear similar to those HPEF. And there's another group where HPEF, the REF has improved, and it has ejection fraction over 40% of HPEF. They are the subgroup a clinically distinct form of persistent heart failure group, and further research has to be done regarding management of these patients. So these are the classification of heart failure. So etiology, I told you, commonest three causes are the coronary heart disease, hypertension, and diabetics. But there are other causes like hypertension, valvular heart disease, cardiomyopathy. I am not going to discuss all these causes. And in addition, there are some triggering factors like anemia, thiamine deficiency, hyperthyroidism, and so on. So clinical presentation is very important. There are various, this is the most important to diagnose these patients. From head to bottom, if you examine, you see from the top in the dilated pupil in the eyes and skin pale gray, cyanotic, dyspnea, orthopnea, lung crackles, anxiety, patient anxious, restless, confused, elevated jugular venous pressure, and maybe cardiac output less if there are ischemia, fatigue, so on. I'll come back to that one. And sometimes it can present atypical symptoms like malaise, confusion, irritability, anorexia, sleep disturbances, and decreased activity and abdominal complaints sometimes. I'm not going to these things. So just skip that one. And typical symptoms are the breathlessness, orthopnea, paroxysmal nocturnal dyspnea, reduced exercise tolerance, fatigue, tiredness, and increased time to recover after exercise. The person who is doing exercise, it found that there's a long time to recover. And then you have ankle swelling. These are the typical symptoms of heart failure. And more specific signs are the elevated jugular venous pressure, hepatojugular reflux, third heart sounds or gallop rhythm, and laterally depressed apical impulse due to enlarged ventricles. But less typical symptoms are there, like nocturnal cough. Most elderly patient, when you complain a nocturnal cough, you have to be very careful. Make sure that you exclude patient and heart failure. And wheezing sometimes, bloated feeling, can get abdominal distension, some due to bile reflux, can get abdominal distension. And patient might come with like a gastritis-like symptoms. And loss of appetite is other reasons can get due to hepatic congestions. Confusion, especially elderly, most of the heart failure patients, they can confuse due to various other causes. I'll mention a few minutes later. And depression, palpitation is a common symptoms, dizziness, syncope, bendopnea. What is bendopnea? Bendopnea is a recent symptoms. 2014 that was introduced. Bendopnea is when the patient is bending and trying to put the shoes, patient get dyspnea, shortness of breath. It's a common symptom in elderly, so it's a good symptoms to ask from your elderly patients whether you have bendopnea. And signs are, again, if the patient is getting overweight, weight loss, cachexia, cardiac murmur, peripheral ankle edema, ankle and sacral edema, pulmonary palpitation, tachycardia, irregular pulse, hepatomegaly, ascites, cold extremities, oliguria, and narrow pulse pressure. Hepatomegaly, sometimes you may see cardiac enlargement due to hepatic congestions. So clinical event that finding useful for identifying patient with advanced heart failure. How do you find the advanced heart failures? These are the good things that patients repeated admission to hospitals, progressive deterioration of renal functions, where the blood urea creatinine rising, weight loss without other causes, cardiac cachexia, intolerance to ACE inhibitors due to hypertension or worsening of renal functions, intolerance to beta blockers due to worsening of heart failure or hypertension, frequent systolic blood pressure less than 90. The low blood pressure, it's another cause for advanced heart failure. Persistent dyspnea and dressing and bathing requiring rest. Inability to walk one block on the ground, flat ground, one block is about maybe 30-40 meters. Recent need to escalate diuretics to maintain volume state, often reaching daily furosemide equivalent dose of more than 180 milligram per day, or use of supplemental metolazone therapy that also suggestive of advanced heart failure. And progressive decline in serum sodium. you see in our medical units, more often we see patients, elderly patient comes with hyponatremia, very common. So that is one of the common cause, it's advanced, maybe advanced heart failure. And if the patient needs frequent ICD shock, that also indication of advanced heart failure. So differential diagnosis of heart failure is a bit of difficult sometimes. That's why you have to ask what are symptoms and signs, what I mentioned. You have to ask and look for the signs of heart failure. And decreased exercise tolerance, fatigue, you can do the myocardial ischemia. Patient or diabetic, mainly hypertension, can come with less pain or without pain. So myocardial ischemia, pulmonary disease, chronic obstructive lung disease, obesity, physical reconsidering, depression. Anemia, other thing, is a common cause of heart failure. Most of the patient has anemia. In the management, some discuss that one. And fluid retention, especially if the patients are on taking NSAID therapy, they can come with fluid retention and hypertension, and heart failure might get worsened. And cardiac abnormalities can get. And shortness of breath may be due to myocardial ischemia, pulmonary disease, chronic obstructive pulmonary disease also. Maybe lung conditions can cause shortness of breath. So precipitation cause for the acute heart failure in these patients are poorly understood. But clinically, we have seen in our patients, and increased sodium diet, another cause. Myocardial ischemia is one of the commonest cause. So a heart failure patient, you have to exclude almost all patients myocardial ischemia. Respiratory and urinary tract infection. Arrhythmia is other common cause, fibrillation. Sometimes when the patient admitted, there may not be fibrillation, but maybe the fibrillation which just precipitate heart failure. And poorly controlled hypertension is another cause for poorly controlled hypertension. And pneumonia is also a common cause for precipitation of heart failure in elderly population. And non-compliant to the medications. Patient may not be taking adequate amount of fluids, mainly diuretics and other drugs. So management, I am not going to talk to you, but I just want to mention, because the next speakers will talk about this, just to mention about it's a multi-dimensional management. So there's from the beginning, you have lifestyle changes, patient education, guideline-directed heart failure therapy now using, which we are almost all clinical and research finding, research analysis drugs. They will start from the guideline-directed therapy is a very important way of management, and device therapy in the advanced cases, and then transplantation and advanced heart failure and palliative care. So many. It's a multi-dimensional therapy. It will be in heart failure management. So in summary, I have time. Heart failure is common after 65 years of age. So any patient who comes over 65 years with dyspnea, fatigue, or atypical symptoms, poor exercise tolerance, or any other symptom what I mentioned, then you have to think about heart failure. A leading cause for the hospital admission, mortality, morbidity in old adults. So this is one of the commonest of admission to the medical units in hospitals. And diagnosis is more challenging, as I told you, is due to morbidity, polypharmacy, cognitive impairment, and frailty of the patients. And it classifies according to the ejection fraction into reduced ejection fraction, or preserved ejection fraction, or borderline, or improved ejection fractions. That's how it classifies. And coronary artery disease, hypertension, diabetes are the three common causes for heart failure in elderly population. And precipitating causes for heart failure are poorly understood, that I already told. However, common causes are like myocardial ischemia, respiratory infection, cardiac arrhythmia, poorly controlled pressure, pneumonia, high sodium intake, and non-compliance. Other commonest cause. So you have to look for all these causes, and also renal failure, sometimes in especially female, renal failure due to urinary tract infection sometimes can come with sepsis and heart failure. So that's also one of the cause, but it has not not a common, but it can present. And management is multifactorial. So thank you very much.
Thank you, Dr. Disanayake, for your lecture on Introduction to Heart Failure. Since we got 10 minutes for the questions, I think if there are any questions, you can ask now from Dr. Disanayake. So can I ask a question from Dr. Disanayake? Now, you said that the diabetes is one of the important cause for the heart failure. Yeah, is it because of the direct mechanism? Is it
no,
because
not direct mechanism. It is due to mainly the ischemic heart disease and age. You know, with the age they get heart failure. Mainly the coronary artery disease. Actually, it's not sort of there are no direct mechanism causing heart failure in elderly population. But you saw the Framingham study. They have found 30 years follow-up patient who has had heart failure when they become old. So that's another cause for the diabetic. Yeah. It's not a direct mechanism except, you know, sort of a patient develop cardiomyopathy or something like that. Maybe asymmetric ischemia, because I have not go through that one. Okay, thank you.
So Mike, please.
Bend-off, Bend-off is a clinical sign. I saw it was introduced in 2014. And it says that when all the patients, when we bending to, you know, put a shoes and something like that, it take about 1 or 2 minutes, you know. So at the time they get dyspnea. So that is one of the symptoms of heart failure.
And that's not seen in other conditions like asthma and causing dyspnea.
May not be, because maybe they had cardiac output problem. So
very interesting.
Very unlikely, because of bending pressure may be causing.
Thank you, very nice.
Our next speaker is Professor Govindan Uni. He is from India and joined with us virtually. Professor Govindan Uni is a professor and medical director, Jubilee Rudalia, Jubilee Vision Medical College and Research Institute, Thrissur, Kerala. Today he is going to talk managing a patient with heart failure in acute care setting.
My dear friends and respected chairperson, it is indeed a pleasure and a privilege for being a guest speaker at the Sri Lankan College of Internal Medicine. So let me first of all thank the organizers for giving me this privilege of addressing this very august gathering. My topic today is managing a patient with acute heart failure in the acute care setting. Now, acute heart failure can be subdivided into acutely decompensated chronic heart failure and de novo acute heart failure. In fact, 80% of all admissions are due to acute decompensated chronic heart failure. Acute decompensated chronic heart failure is an integral part in the natural history of chronic heart failure. It is only 30% of patients who gets admitted with an acute heart failure have de novo acute heart failure. And 50% across the world have heart failure with preserved ejection fraction. This percentage will depend on the society, on the population. As the aging population increases, in societies where the aging population is higher, it can go even up to 70%. So it depends on the population. And as already said in the introduction, it is the most frequent cause of unplanned hospital admission in those above the age of 65 years. When you compare acute decompensated heart failure with chronic heart failure, during the last few decades, there has been several advancements in the management of chronic heart failure, that the mortality is slowly coming down, the morbidity is also coming down in chronic heart failure. However, unfortunately, such things have not happened in acute decompensated heart failure. Despite multiple trials of promising therapies, the standard of care, that is decongestion and hemodynamic support, with intravenous diuretics, vasodilators, and inotropes remains largely unchanged during the past 45 years. So unfortunately, nothing much has happened in the realm of acute decompensated heart failure compared to chronic heart failure. Now, this is the natural history of chronic heart failure, and you can see that the downhill course in chronic heart failure is interspersed with acute exacerbations or recurrent acute heart failure. You can also see that after an acute heart failure, the patient improves, but it does not reach his original status. The result that you can see that the patient gradually goes downhill as time passes on. Thus, hospitalization for acute heart failure is one of the most important predictors of post-discharge mortality and readmission in chronic heart failure. Now, as you know, congestion is the basic problem in acute heart failure. Congestion can be systemic or can be pulmonary. Either way, there is little consensus regarding assessing and grading congestion. Unfortunately, there is also little data, limited data on the association between congestion and symptoms, on the association between congestion and changes in body weight, or even on the association between congestion and clinical outcomes. In fact, more than 30% of patients, even though they improve, they report minimal weight loss or actually gains weight during hospitalization. And 30% of people had few signs and symptoms of volume overload, and their BNP levels were also low. This is because in these patients, there is no actually volume overload. What is happening is rapid redistribution of blood from the splanchnic circulation, from the cutaneous circulation to the central circulation, and that leads to congestion. So in about a third of patients with acute heart failure, there is no volume overload. It is only redistribution of fluid. And so looking by the weight loss alone may not give us the correct idea about congestion. It is important to look at the precipitating factors, because unless you treat the precipitating factors, the patient is going to come back with recurrent acute heart failure. Probably in a patient with chronic heart failure, the most important cause is non-adherence. Non-adherence to medication, non-adherence to diet, non-adherence to lifestyle. Well, acute coronary syndromes, acute myocardial ischemia is very common cause and should be looked for because it is eminently treated. Another treatable condition is uncorrected high blood pressure, which can be treated, and heart failure can be prevented in patients by treating blood pressure alone. Arrhythmias, especially atrial fibrillation, new onset, can push a patient with borderline heart failure into acute heart failure. Negative inotropic drugs like verapamil, diltiazem, or even inappropriately high doses of beta blockers can precipitate an acute heart failure. And don't forget pulmonary embolism, because again, it is a disease which can be treated. Then there are non-cardiac drugs like non-steroidal anti-inflammatory drugs, or steroids, or diabetic drugs like thiazolidine-diones, which all result in fluid retention. Alcohol abuse, uncontrolled diabetes, uncontrolled thyroid status, concurrent infections like pneumonia and viral illness, and finally, other acute cardiovascular diseases like endocarditis, for example, or a myopericarditis, or maybe an undetected aortic dissection. So it is important to look for these precipitating factors. Now, how can you predict the mortality when the patient comes to the emergency department? If you look at the ADHERE data, it is very simple, because there are only three important predictors of mortality. That is blood urea, systolic blood pressure, and serum creatinine. If you look at this chart, the ADHERE chart, you can see that the mortality is as low as 2.14%. In somebody whose blood urea is less than 43, systolic blood pressure is more than 115, and serum creatinine is normal. And that rises 10 times to 21.94% if the blood urea is more than 43, if the blood pressure is less than 115, and creatinine is more than 2.75. So these are the three important predictors of mortality in the emergency department. Well, let us now come to management. Timely initiation of therapy is very important, because it has been found that there is a positive association between the short time from admission to diuretic administration and improvement in hospital survival. Like your time to balloon time or the time to needle time in an acute STEMI, there is also a time to treatment concept in acute heart failure. The earlier you give an IV diuretic, the better the in-hospital survival is. Well, treatment is basically intravenous, either vasodilators or diuretics, and usually a combination of both without wait for additional testing. That is very important. With the clinical diagnosis of heart failure, start diuretics. Don't wait for confirmatory results. In the presence of obvious fluid retention, diuretics are the first line choice, whereas you can add vasodilators to reduce filling pressure, arterial vasodilators to reduce the afterload, and venous vasodilators to reduce the preload, but they can be given only if the blood pressure is normal or there is a preserved systolic blood pressure. Unfortunately, it has been found that both diuretics and vasodilators, even though they produce short-term improvement, there is no prognostic benefit in the long term. And when you look at inotropes, which should be restricted to patients with cardiogenic shock, it has been found that in the long term, it actually increases mortality. Forget about prognostic benefits. They are harmful. They increases mortality. And hence, inotropes should be given only if there is evidence of cardiogenic shock. So the patient with suspected acute heart failure comes to the casualty, to the emergency department. The first thing in the emergency department to do is to rule out these two important problems. One, cardiogenic shock, and two, respiratory failure. If the patient has got cardiogenic shock, he should get circulatory support, which can be pharmacological like inotropic support or mechanical like an IABP. If the patient has respiratory failure, he should get ventilatory support, oxygen, non-invasive ventilation, or maybe even mechanical ventilation. If neither of these things are there, he requires stabilization and transfer to an ICU. Now, in the ICU, in the first 60 to 120 minutes, maybe the most important thing is to identify these 5 precipitating causes, because these 5 causes have specific treatment, and this specific treatment has to be initiated immediately. A mnemonic to remember it easily will be CHAM: acute coronary syndrome, hypertensive emergencies, arrhythmias, acute mechanical causes, and pulmonary embolism. If any of these things are there, the treatment is different and that goes into a special category. If none of these things are there, then you have to evaluate the patient clinically based on congestion and perfusion. Remember, identification of congestion and perfusion is purely clinical. No investigations are required. Perfusion is assessed by the skin perfusion, by looking at the extremities warm or cold, by looking at the urine output and hence looking at the renal perfusion, by looking at the mentation and dizziness, which gives us an idea about cerebral perfusion, and finally, pulse pressure, low pulse pressure tells you that the perfusion is also there. On the other side, if you look at congestion, bistellar crepitation suggesting pulmonary congestion, history of orthopnea or paroxysmal nocturnal dyspnea, peripheral edema, raised jugular venous pulsations, congested hepatomegaly, ascites, and hepatojugular reflux. Now, based on these clinical factors, you can divide patients into the best patient who is warm and dry, who is not congested and who is well perfused, and the worst patient is cold and wet, who is congested and hypoperfused. And in between, you have the warm and wet patient who is congested but well perfused, and the cold and dry patient who is not congested but has hypoperfusion. Remember that hypoperfusion is not synonymous with hypotension. Hypoperfusion is a clinical diagnosis based on characters that I have already said, even though in most of the cases, hypotension is accompanied by hypoperfusion. So try to assess hypoperfusion separately from blood pressure, separately from hypotension. Now, the dry and warm patient is the most easy to treat. He does not actually require intravenous drugs. All he needs is to adjust the oral drug therapy, up-titrate the guideline-directed medical treatment like RAS blockers and beta blockers. Now, the dry and cold patient who is hypoperfused and hypovolemic, usually the first thing is to give some fluid challenge to make sure that he is perfused properly. Sometimes, most of the cases, the fluid challenge works. If it does not work, then one may have to consider inotropic agents if the patient continues to be hypoperfused in spite of fluid challenge. The wet and warm patient usually has typically elevated or normal systolic blood pressure, and you can divide them into 2 groups. One is the vascular type, where the predominant thing is hypertension and fluid redistribution, where vasodilators should be the drug of choice. Plus, of course, they will also require diuretic, but vasodilators gets predominance over diuretic. And the other type, where there is the cardiac type, where there is fluid overload and congestion predominates, one has to give diuretic and vasodilators and ultrafiltration if required. So the vascular type is basically fluid redistribution, and the cardiac type is basically volume overload or fluid accumulation. And the most difficult patient is the wet and cold patient. Looking at the blood pressure, if the blood pressure is less than 90, he will require an inotropic support, may require vasopressors if the patient does not respond to inotropic agents. Once the perfusion is corrected, he will require diuretic, and finally, may require mechanical circulatory support like IAPP or maybe an ECMO if there is no response to drugs. Whereas if the blood pressure is more than 90, one can carefully try vasodilators and diuretics. But of course, if the patient does not improve, inotropic agent has to be tried. Now, what about the good old drug, morphine, which was initially in olden days given left and right as part of sedation? Well, it is a good drug. It do have central actions and reduces sympathetic tone, reduces anxiety, reduces tachycardia, and thus reduces myocardial oxygen demand also. It has got a dilating arterial function and thus reduces afterload. It also has a venous dilator action and thus reduces venous return, reduces preload, and improves pulmonary congestion. But you have to be careful in conditions of hypotension, in conditions of bradycardia, or high-grade atrioventricular block. Now, the present concept is that morphine should not be used as a routine treatment, because if we look at the benefit-risk ratio, it has been found that the risk is higher than the benefit. So morphine is not now a routine drug, even though you can give in patients who are very anxious, who have tachycardia, who have high blood pressure, and who do not have any respiratory depression. So only in selected patients can you give morphine. Diuretics, as I said, is possibly the mainstay in the treatment of acute heart failure. However, how much diuretic you have to give in patients is largely empiric. It has to be determined, decided by the patient and the physician and the patient at the bedside, because it depends upon a lot of things. You should not give inappropriately low doses, because inappropriately low doses result in persistent congestion. And persistent congestion is the commonest cause of readmission, rehospitalization. Whereas when you give the other extreme, inappropriately high doses, you get hypokalemia precipitating arrhythmias, hyponatremia, hypovolemia. All these can lead to hypotension, hypoperfusion of the kidney, and worsening in renal function. The result will be that you will have to scale down RAS blockers, you will have to scale down beta blockers, all of which are good drugs in the long term. Moreover, stimulation of the renin-angiotensin-aldosterone system and the sympathetic nervous system by hyponatremia, hypovolemia, and hypotension actually worsens heart failure, because our aim is to suppress the RAS system as well as the sympathetic nervous system. So as far as diuretics is concerned, the principle is the lowest dose that maintains euvolemia, which I would say is a purely clinical decision and requires a lot of clinical skill to identify that which is neither over-congested nor under-congested or dehydrated. Now at the other extreme, we have patients with diuretic resistance who do not respond to higher doses of diuretics. It could be due to inadequate diuretic dosing. For example, if you give furosemide 12th hourly, furosemide acts only 6 hours, and so the rest of the time there may be avid water and sodium reabsorption. So you may have to give it twice or thrice daily. When you are giving orally gut edema, again with furosemide absorption is reduced by gut edema. Or in presence of kidney disease, none of these diuretics might work. And finally, when there is blood pressure is low, as I already said, renal perfusion is low, and the diuretics do not work. And look at other medications like NSAIDs or, as I already said, thiazolidine diuretics. One of the ways to overcome loop diuretics is to give sequential nephron blockade, which means you give a thiazide blocker or a distal convoluted tubule blocker, and that may produce diuretics. Now, the proximal convoluted tubule blocker, that is the SGLT2 inhibitor, so far there has been no studies except the recently published soloist trial. But people are very, very excited about giving SGLT2 inhibitors and producing sequential nephron blockade, proximal blockade, and loop diuretic. But we will have to wait for more data before advise SGLT2 inhibitors in this clinical setting. Well, one may have to give positive inotropes to increase the augment the blood flow and improve diuresis. Vasoactive agents has been tried a lot, but unfortunately, all of them have given disappointing results. Whether it is dopamine or nesiritide or tolvaptan, all of them have been disappointing. Finally, of course, ultrafiltration and maybe even peritoneal dialysis. Coming to vasodilators, can be given in patients with acute heart failure without significant hypotension. I would change that hypotension to hypoperfusion because, as I said, perfusion is more important than blood pressure. The two commonly used vasodilators are nitroglycerin, which is a venodilator, and nitroprusside, which is an arterial vasodilator. Both of them have produced short-term improvement, but improved outcomes in the long term are lacking with neither of these drugs. Two other drugs that has been tried are nesiritide, a recombinant form of human BNP, and serelaxin, a recombinant form of human relaxin 2. Both of them have showed short-term benefit, but unfortunately, no long-term benefit with these drugs also. Vasodilators are preferred when there is high blood pressure, when there is ischemic heart disease, especially nitroglycerin, and when there is mechanical complication like mitral regurgitation. As already said, let me re-emphasize that it should not be used in terms when there is hypoperfusion and cardiogenic shock. Excessive hypotension can worsen renal function, and so the dose has to be titrated very carefully. And be careful in these three groups of patients: renal dysfunction, elderly, and severe aortic valve disease, aortic valve stenosis. Well, what is the blood pressure threshold for vasodilator therapy? As I already said, I personally believe that blood pressure should not be a threshold. The threshold should be perfusion based on skin, kidney, and the brain. Clinical assessment of skin, kidney, and brain. The European Society of Cardiology guidelines have fluctuated over the last decade. 90 in 2008, 110, 2012, 90 in 2016, even though there were no relevant studies to focus on this topic. So what I would say is that look at perfusion. If the peripheries are warm, whatever is the BP, you are still justified in giving some vasodilators, but be careful, especially in those with renal failure, in those elderly, and those who have severe obstructive valvular diseases. Inotropes, as I said, has been found to increase the mortality, and so should be given only if there is definite evidence of end organ hypoperfusion. Dopamine, dobutamine, milrinone, and levosimendan are the drugs that has been given. All of them have produced short-term improvement, but no long-term benefit. In fact, long-term mortality has been increased in these patients. Dose-limiting adverse effects, including atrial and ventricular arrhythmias, which can be fatal and has been associated with increased mortality. And as the patient has hypotension and hypoperfusion, this chart may be useful because it tells you what is the vascular action of the inotropes. At one end, we have pure vasoconstrictor like norepinephrine, and at the other end, we have pure vasodilator like isoprene. And in between, we have high and low dose of dopamine and dobutamine. So depending on the blood pressure and perfusion, you can choose the inotropes based on this chart. Now, vasopressor therapy is even worse, and it should be used only if patient does not respond to inotropes, continuing to have marked hypotension. So it is only a temporary measure to preserve systolic blood pressure at the cost of increasing afterload, decreasing cardiac output, increasing oxygen demand, increasing myocardial stress. They are not good drugs, only as a last measure. And so should be limited to patients with persistent hypotension, symptoms or evidence of consequent end organ hypoperfusion, despite optimization of filling pressures and use of inotropic agents. So real last line drugs. Norepinephrine and high-dose dopamine are the drugs that are used. Finally, do not forget influenza and pneumococcal vaccines before discharge. It is a class 1 indication because pneumonia and influenza are causes of readmission very, very frequently. When a patient who is already on a RAS blocker, beta blocker, and MRA, chronic maintenance treatment of guideline-directed medical treatment, comes with an acute heart failure, the most important thing is to make sure that you do not stop GDMT. Continue GDMT unless it is absolutely essential. If there is hemodynamic instability or a hyperkalemia, for example, there is no way. But if possible, continue GDMT. Continuation of RAS blockers and beta blockers is usually well tolerated. You increase the diuretic and continue with beta blockers. And it has been found that outcomes are better in those patients where you continue guideline-directed medical. So outpatient GDMT should be continued in the absence of hemodynamic instability or other contraindications. And so when the time of discharge, long-term treatment, optimize the diuretic, which I said is the most important treatment part in acute heart failure management. Maintain euvolemia at the lowest dose of diuretic. Treat precipitating factors. And in preserved ejection fraction heart failure, treat comorbidities like hypertension, COPD, etc. Whereas in reduced ejection fraction, start disease-modifying therapy like RAS blockers, beta blockers, and mineralocorticoid receptor antagonists, and now also SGLT2 inhibitors. And finally, non-pharmacological treatment, surgical options, LV-assisted devices, cardiac resynchronization therapy, and transplantation. So let me conclude here and once again thank the Sri Lankan College of Internal Medicine for giving me this honor and privilege of addressing this very august gathering. Thank you very much.
Professor Govindan Yuni is happy for any questions and in discussions. Any questions?
So can I ask a question? Professor Yuni, very interesting topic that you covered. Want to ask two questions. The first question is, so when a patient has low blood pressure, we tend to give diuretic fusible infusion over boluses. Is there any evidence for that? I know that there was a study called SOUL study, or DOSE study, I think, which was done with fusimide and the boluses was the infusion. But just want to ask, what's your view about giving infusion over boluses in a patient with low blood pressure? And the second question is the place of metolazone in patient with acute heart failure.
Yeah, with respect to the first question, as you rightly said, the only trial was the DOSE trial, where bolus dose was compared with frequent repeated, where infusion was compared with frequent repeated doses. And they found that long-term there is no benefit. Whether you give infusion or you give repeated doses, long-term there is no benefit. But there were some minor short-term benefits. The patient became asymptomatic earlier. Congestion was relieved earlier when you give infusion. So you are justified in giving an infusion if the patient does not respond to frequent bolus doses. With respect to metolazone, it is a thiazide-like diuretic acting on the distal convoluted tubule. So as I said, as a sequential nephron blocker, metolazone has a definite role in the management of diuretic resistance in acute heart failure. Although, if there is reduction in GFR, because when the GFR is reduced, thiazides like hydrochlorothiazide or chlorthalidone do not work. But metolazone works because metolazone reaches the renal medulla, not only through glomerular filtration, but also through the blood circulation. So in a patient with the low GFR, if you want to give sequential nephron blockade, metolazone is the number one drug.
Thank you.
In the absence of any questions, thank you very much, Professor, for your presentation.
With that, we will move to the next lecture. The next lecture is on current evidence of HFrEF and HFpEF. The next lecture will be delivered by Professor Stuart D. Russell. Professor Russell, MD, FRS, FACP, is the Regional Director of Heart Failure, Medical Director of Mechanical Circulatory Support at Duke University Medical Center, and Professor of Medicine, Duke University Medical Center. Professor Russell, in fact, is supposed to join us virtually, but unfortunately, due to some unknowable reason, he would not join us virtually. Instead, we will telecast his recorded version of lecture, so he won't be able to take your questions at the end of the lecture.
Good morning. My name is Stuart Russell. I'm Professor of Medicine at Duke University. It is my pleasure to talk with you today about the current evidence of heart failure with reduced and preserved ejection fraction in terms of therapy that we use for these patients. Here are my disclosures. I have research support from the NIH, do some DSMB work on LVAD trials with Habit, and a consultant for Medtronic, again, on left ventricular assist devices. My outline today will really be to focus in two areas. First, be to really talk about the guidelines in heart failure therapy for patients with reduced ejection fraction, and focusing specifically on the ARNIs, and then the more recent drugs that have been evaluated in heart failure, which are the SGLT2 inhibitors. And then briefly to talk about therapies for heart failure with preserved EF, focusing on amyloid as a therapy or a strategy to treat patients. First, some definitions, and I talked a lot about HFrEF and HFpEF. So HFrEF, or heart failure with reduced ejection fraction, are patients with an EF less than 40. And are the patients that have been commonly studied over the years in clinical trials for heart failure. Contrast that with HFpEF, which are patients who have an ejection fraction greater than 50%. In the past, were thought of as those who have diastolic dysfunction. Can be challenging to diagnose, and a lot of these patients come in with COPD or asthma exacerbations and truly do have heart failure instead. And unfortunately, we don't have great therapies for them. There are also some midline groups, those with an EF between 40 and 50%, or those whose EF was lower that then have had some recovery, but not complete recovery of their LV function. I tell the cardiology fellows that they should all think about heart failure because it really is a booming business. Data from 2017 showed that over 6.5 million Americans have heart failure. And there are about 1 million new cases diagnosed annually, with unfortunately still a bad survival rate at about 50% at 5 years. As you can see, with aging, the incidence of heart failure goes up, and there's about 43 per 1,000 people that develop heart failure over the age of 85 each year. We thankfully have a lot of clinical trials that have been positive over the years, starting with the ACE inhibitors before 2000, the ARBs, beta blockers, defibrillators and CRT therapy, and then more recently, the ARNIs in the Paradigm trial and the SGLT2 drugs. And I'm going to focus on those two. We're also looking at newer agents that are not yet available that may be beneficial for heart failure patients as well. Based on all of those studies, the AHA American College of Cardiology guidelines in 2010 came out with this treatment algorithm. Everybody with HFrEF, whether they be class 1 to class 4, should be on an ACE or an ARB and a beta blocker. Diuretics as they need. And then you should split it based on your patient. If their renal function is okay, add an aldosterone antagonist such as spironolactone. If they've got blood pressure to tolerate it, take them off of their ACE or ARB and initiate an ARNI. And I'll talk more about ARNIs in a minute. If they're black, add hydralazine nitroglycerin. Think about ICDs and CRTs. And if they're on maximal beta blocker, they still have heart rate to act, not because of mortality benefit, but because of a reduction in heart failure hospitalizations. Think about the addition of vigabatrin. So a lot of different options for our patients on a baseline of ACE and beta blocker. So what got us to get into ARNIs? Now, what about these new drugs, the SGLT2 inhibitors, and what should we think about with them? So an ARNI is a combination of an angiotensin receptor blocker plus a neprilysin inhibitor. The only one that's available today is a combination of valsartan and sacubitril. Valsartan, as you know, is an angiotensin receptor blocker and blocks the effects of angiotensin on the receptor. Without that blockade, you have more vasoconstriction with hypertension, increase in sympathetic tone. So those detrimental effects are blocked with valsartan. On the other hand, a neprilysin inhibitor blocks the breakdown of BNP. BNP is the only beneficial neurohormone that gets upregulated in heart failure. And so by blocking the breakdown of BNP, you get further vasodilatation, a decrease in sympathetic tone, decrease in aldosterone levels, and some natriuresis and diuresis. So beneficial effects that are kept around longer with this. Initially, there were studies with ACE inhibitors and neprilysin inhibitors, but unfortunately, there's a high incidence of angioedema, and those were stopped. But the ARB valsartan plus sacubitril has been studied for it. And the study that initially looked at this was the Paradigm trial, which looked at 8,400 patients with class 2 to class 4 heart failure with an ejection fraction rate of less than 40%. In addition to that, they also had to have a pro-BNP over 600 or a BNP over 150 and a heart failure hospitalization within the last year. The endpoint was a common one of composite death from cardiovascular causes or heart failure hospitalizations, with the usual secondary endpoints that we see. Important exclusion criteria that you need to think about with your patients is that patients who had symptomatic hypertension on these agents were excluded, regardless of their blood pressure. Additionally, anyone with a blood pressure less than 100 at screening or 95 at randomization was excluded. Patients with poor renal function, a GFR less than 30, were excluded, and those that had hyperkalemia were also kicked out, as well as the rare patient that had a history of angioedema with either an ACE or an ARB, not just with an ACE inhibitor, were excluded from the trial. Well, here's the primary endpoint of cardiovascular death or heart failure hospitalization. And as you can see, the group who received valsartan sacubitril benefited compared to those with enalapril. There was a 20% reduction in the primary endpoint and the number needed to treat of 21 to get a benefit in terms of reducing cardiovascular death or heart failure hospitalization. Any of the secondary outcomes that people looked at, death from any cause, death from cardiovascular causes, first hospitalization for worsening heart failure, all went in the right direction with this. And so all the way down the board, we've got a drug that now beats enalapril, which was thought to be the cornerstone of our heart failure therapy. Additionally, if you look at the adverse events, the one that you need to worry about is symptomatic hypertension. 14% in those on valsartan sacubitril compared to 9.2% with enalapril. Everything else went in the right direction. There was less hyperkalemia, less renal insufficiency, less incidence of cough, reduced discontinuation related to the adverse events that were there. So a good drug if the patient can tolerate it because of a reduction in blood pressure. Now, the American College of Cardiology and American Heart Association recently came out with their updated guidelines. And they talk about contraindications to these therapies. The big one to remember is that because of the risk of angioedema with ACE inhibitors, you have to be off an ACE inhibitor for at least 36 hours before you start this agent. And if there's a history of angioedema with either an ACE or an ARB, you need to not think about starting the drug. Cautions are in those with renal impairment, those that have a reduced blood pressure because you will most likely drop it further, and those that are actually too dry because of the diuretic effect related to the sacubitril. Beyond that, most patients tolerate them well, and it is something that you should really think about switching all of your patients to because of the mortality benefit compared to an ACE inhibitor, enalapril. So the second new agent are the diabetic drugs, SGLT2 inhibitors. And the first question is, why are we using diabetes drugs for patients with heart failure? And it really gets to the point that the FDA has mandated for about the last 20 years that all new therapies being studied in patients with diabetes have to have cardiovascular outcome events. So they look at the incidence of MIs, they look at heart failure, they look at cardiovascular death, and they found with these therapies that there actually was a benefit. So in both studies with empagliflozin and in the Canvas program, patients for the incidence of cardiovascular death and heart failure hospitalizations had a reduction in events if they had diabetes. Now, interestingly enough, in Canvas, patients with a history of heart failure actually did better than those who did not have heart failure. All of these patients are diabetics, but it made the investigators think, maybe these could be beneficial to patients with heart failure, regardless of whether they do or don't have diabetes. And so now there have been 2 trials resulted in approval of drugs for this. The first, the DAPA-HF trial with dapagliflozin, and then more recently, the Emperor Reduced trial with empagliflozin. As you can see here, 8,000 patients between the 2 trials have been studied, all with an ejection fraction less than 40%. In the DAPA trial, 42% had diabetes. In the EMPA trial, 50%. So over half of the patients did not have diabetes that were being studied with this. Clinical endpoints were similar in the trials, cardiovascular death and heart failure hospitalizations, with about a 1.5 year median follow-up. And as you can see, there was a reduction in events in the DAPA and in the EMPA arm compared to placebo in patients with heart failure. That reduction was there regardless if they had diabetes or not, regardless of their age, their sex, or if they were on a baseline ARNI or any other therapy for that. So 2 drugs in the same class showing a benefit in patients with heart failure, regardless of diabetes standpoint, in terms of the events that we care about, such as death and heart failure hospitalization. Other events that were looked at, including cardiovascular death alone, heart failure hospitalizations alone, and renal protection alone, all went in the right direction, with a 14% reduction in cardiovascular death, 26% reduction, as I mentioned, in death plus heart failure hospitalization. Heart failure hospitalizations were reduced by 31%, and improved kidney function in 38% of the patients. This is a drug that we should get our patients on. Now, the next question is, how do they work? And honestly, I think there's a lot of hypotheses out there, and we honestly don't know today. Could it be that they stimulate diuresis versus osmosis by losing glucose through the kidney? Does it have something to do with improving myocardial energetics or reducing LV mass, improving systolic and diastolic dysfunctions? A lot of papers are being presented right now on this, but the bottom line is we don't know. What do we know? The drugs work, and we should use them in our patients with heart failure. Some things that you do need to worry about is that these drugs are not approved for use in patients who have type 1 diabetes. Type 2 is okay. No diabetes is okay, but not type 1. Worry about those that have known hypersensitivity to a drug. Worry about those who have really kind of advanced renal insufficiency. Things that do happen occasionally are an increase in mycotic genital infections and an increase in urinary tract infections. Additionally, there's some diuresis that occurs, and so be careful in patients with impaired renal dysfunction and maybe back off on their diuretics in that setting. So where are we in theory today? If you take somebody with heart failure on no agents, they have about a 35% 2-year mortality. You add an ARNI, a beta blocker, an aldosterone antagonist, and an SGLT2 inhibitor, and you've reduced that down to less than 10% mortality at 2 years. Adding all 4 of these together really is beneficial, and the guidelines that again came out a couple weeks ago have now really shown that. Where in difference to the past where they talked about an ACE or an ARB, now we are saying that an ARNI is a preferred agent for all patients with an ejection fraction less than 40%. For those who have okay renal function and no hyperkalemia, add the aldosterone antagonist. For those who have an EF less than 40 with class 2 to 4 heart failure, also add an SGLT2 inhibitor. For those who have volume overload, add a diuretic. For those who, despite all that other therapy, are still symptomatic and also are Black, think about adding hydralazine isosorbate. So we now have a 4 cornerstone to our therapy instead of the 3 that we've been really working with for the past year. So that's HFrEF. What about HFpEF? Unfortunately, the data is less promising in HFpEF compared to HFrEF. First, no difference whatsoever. This is an old paper from the Mayo Clinic showing that the survival rate is no different between those with HFpEF compared to those with HFrEF. Unfortunately, we have no good therapies for HFpEF patients. In contrast to, in blue here, what we see with HFrEF, whether it be a beta blocker, an ARB, an ACE inhibitor, digoxin, no mortality benefit whatsoever in the HFpEF population. Because of that, the guidelines really are much more generic. They suggest treating blood pressure as you normally would, use diuretics for symptomatic relief, revascularize patients who have coronary disease and either angina or myocardial ischemia, treat atrial fibrillation as you normally would, use beta blockers and ACE inhibitors to treat hypertension, although there's no benefit that's been shown with those. And then the one thing that they're now suggesting is to think about potentially using an aldosterone antagonist in patients with HFpEF if their renal function is less than 2.5 for creatinine. The reason for that is really the TopCat study. The TopCat study took over 3,000 patients with HFpEF and randomized them to spironolactone or placebo. Follow up with 3.5 years with the primary endpoint of death plus heart failure hospitalization. And as you can see here, no mortality benefit in terms of the primary endpoint. But if you look at just heart failure hospitalizations, you see just a slight statistically significant reduction in events with spironolactone compared to placebo. The other interesting thing about this trial is that there was a difference in outcomes depending on where you were. And so the investigators looked at differences really based on regional variation. This trial was performed in North and South America and also in Eastern Europe. And so they could split the groups that way and found that in the Americas, those who received spironolactone, in the dashed red here, had an increase in potassium, as you would expect, compared to those on placebo. In Russia and Georgia, there was a slight increase, but it wasn't as significant between the two. Similarly, if you look at renal function measured by creatinine, no change between the two groups, placebo versus spironolactone in Russia and Georgia, but a little bit of a bump in the Americas, suggesting that perhaps there's a difference in these patients and how they might react to the drug. So that's kind of potassium and creatinine. What about endpoints? And if you look at the primary endpoint here, in the Americas, there was a statistically significant difference between those who received placebo and spironolactone. There was none in Russia and Georgia. And similarly, if you look at just heart failure hospitalization, again, a reduction in heart failure events in the Americas, but not in Russia and Georgia. Also, if you just look at the overall incidence of events, much lower there, suggesting that these patients are different in some fashion that we really today don't understand. But potentially in the Americas, these drugs are helpful, or in a different group of patients, they appear to be less helpful, which left the investigators to say there are possible clinical benefits with spironolactone in patients with HFpEF from the Americas. And based on that, get the recommendation for a 2B out. Now, what about ARNIs? They're great in patients with heart failure. They're better than enalapril. How about in HFpEF? And so 4,800 patients were randomized to sacubitril valsartan compared to valsartan. Normal inclusion criteria, primary endpoint being the same. And unfortunately, a trend in reduction in hospitalizations, but no difference in mortality with this. And based on that, there's no really benefit today that we think to starting patients on this. Part of the reason for that may be that a lot of these patients with HFpEF may have something else going on. In contrast to HFrEF, the HFpEF patients are very heterogeneous. And one of the things that we see is amyloid, which is extracellular infiltration throughout the heart, involving both the myocardium as well as the valves and the perivascular tissue. We all know amyloid here. This is a biopsy looking at it surrounding myocytes. It stains red with congruent staining, and then when you put it under a polarizing microscope, you get these birefringent green fibers that we learned about in medical school. Well, how often does this happen in HFpEF? And this is from an autopsy study at the Mayo Clinic, and you can see that compared to controls, 19% of the patients with HFpEF dying at the Mayo Clinic had amyloid. So 1 out of 5, and maybe they would be treated differently. I recently was part of a study looking at biopsying patients with HFpEF. We found that 14% of the patients with clinical HFpEF had amyloid. They tended to be older, were more hypotensive, had a lower BMI, and fewer comorbidities compared to the rest of the patients in our HFpEF population. So somewhere probably between 14 and 20% of your patients with HFpEF may have amyloid. Is that important? And the answer is yes. We now have therapies for that, whether it be to inhibit the synthesis of the protein or to stabilize this abnormal protein that can be there. And one of the studies there was with a drug called tafamidis, which actually stabilizes the tetramer of these patients. This was studied in 400 patients in a 2:1:2 dose versus placebo study. And as you can see here, it took a while, but there was a mortality benefit to patients receiving tafamidis versus placebo. And more importantly, an improvement much more quickly in functional capacity in those with tafamidis. Other drugs have not showed a mortality benefit, but have not been studied for mortality, but also show an improvement in functional capacity. So how do I treat my HFpEF patients? Reduce congestion, treat their hypertension, think about other causes such as infiltrative processes of amyloid, go to where they are, treat them differently, don't lump them all together. Thank you very much for your attention.
I am going to present the last speaker for the symposium today. He is Dr. Madhav Disanayaka. He is a board-certified consultant cardiologist at Worthing Hospital, Western Sussex, NHS Foundation Trust. He is the clinical director in medicine with special interest in complex devices and heart failure. He is going to speak today management of advanced heart failure. But unfortunately, he is unable to join virtually. We are going to listen to a recorded speech.
Thank you very much for asking me to talk today. My name's Madhav Disanayaka. I'm a consultant cardiologist in complex devices and heart failure, practicing in the UK. On the south coast in Sussex, which is a beautiful, picturesque part of the country, on a nice sunny day with the beaches as well as beautiful countryside. In particular, we have the South Downs, a very picturesque part of the country with a 100-mile trek across it, which people tend to cycle and walk along parts of it. Worthing is a town on the south coast with beaches, and the hospital I work at is Worthing Hospital, which is part of Western Sussex Hospital Foundations. We serve a population of about 500,000 people, generally quite wealthy and elderly with a significant heart failure burden. My aim is to show you how I recognise and treat advanced heart failure, with a huge emphasis on treating patients at home in an ambulatory fashion and avoiding hospital admission. This is not only good for the NHS, but also better for the patient and their family, keeping them at home for as long as possible, and ideally to avoid hospital altogether. I'll highlight this with some cases, revealing some of our best practice. Importantly, it's a team-based approach. We have 3 heart failure consultants, including myself. There's a device fellow as well as cardiology registrars. There's 5 specialist heart failure nurses who tend to run the service. There's a complex device nurse who has counselling skills. We have access to the rehab team, as well as palliative care in the community and the hospice, including pharmacy, EP services, cardiac structural services, and ultimately the wider medical service as well. As you all know, heart failure tends to follow a trajectory awfully similar to cancer. There's often a period of stability with deteriorations and a rebound to usually a lower baseline than before, but this general progression towards end-stage heart failure. I tend to look at advanced heart failure as 2 or more hospital admissions over the last 12 months, which is likely to result in a change in my practice from disease prevention to really concentrating on quality of life. This often involves stopping ACE inhibitors and spironolactone and instead switching to diuretics and opiates.
Importantly, along this journey, the patient needs to be aware of this shift in treatment as well as his family. My first case is a 78-year-old retired pilot. He has underlying ischemic heart disease, he's had previous bypass surgery, and ultimately has a severely impaired LV with left bundle branch block and had a CRT-D device implanted 12 years ago. He's had this changed a few years back and he's generally potted along pretty well. He's had an admission a few years ago. Just so people are aware, CRT stands for cardiac resynchronization therapy, where I implant a lead in the right ventricle and a lead through the coronary sinus into a branch at the back of the heart to enable capture of the left ventricle and therefore enabling more coordinated contraction and ultimately to try and improve cardiac output. Importantly, most of the devices in the UK now have home monitoring capabilities via Bluetooth and Wi-Fi. Using this in a box that patients often have by their bedside, they can transmit data daily from their device for particularly rhythm disturbances as well as lots of other. This gets passed on to us, and often via some modulation I can get scoring systems. So this is probably one of the most sophisticated ones out there at the minute. Via Boston Scientific, it involves data looking at heart rate, respiratory rates, thoracic impedance. It can even listen to S1 and S3 heart sounds and ultimately give me a score of a patient's likelihood of deterioration into heart failure. When patient scores increase over a period of time, like we did with our patient, and interestingly he was aware of some breathlessness, some leg swelling and some orthopnea, we advised him to attend our React service I set up that is an early assessment service for heart failure, and it's basically an admission avoidance tool whereby rather than waiting for patients to develop lots of symptoms and be referred via their general practitioner, the patient can refer themselves or in this case be picked up from their device and advised for optimization again of their treatment. So it's a specialist nurse run service with supervision usually by myself. The heart failure nurses look at themselves like this, or like this. I tend to imagine it looking like this. Treatment as necessary. Far less sophisticated and involves just 2 reclining chairs that I managed to pick up from the renal dialysis unit with access to a toilet and ultimately a quiet place to enable discussions with the family. I have a little box with IVs and enabling treatment with IV diuretics. The important thing is it's enabling me to have access to echocardiography, pacing checks and the wider cardiac team. Much, but actually in the first year alone it resulted in nearly 1,000 bed days saving, which is about £1 million. The patient, as I said, can activate React themselves by giving us a call and we'll often see them the next day. Similarly, the general practitioner and the community matron can also refer in. Most patients tend to be managed as an outpatient basis, but occasionally we do. With my patient, he was reviewed in React and there was a fair burden of edema. He was switched to IV diuretics for 3 days and then ultimately returned back to his oral medications. His ACE inhibitors had to be stopped as his renal function deteriorated, and ultimately after review over the next few weeks his weight had fallen 7 kilos and discharged back to community. Over the course of the next 18 months he has had 2 more attendances, but the important thing is he's still at home with no hospital admissions, which is definitely a bonus for the NHS. It demonstrates how REACT can work efficiently where patients can be detected very early in their symptomatology rather than waiting for severe breathlessness, which is often much more difficult to treat. My second case is an 80-year-old chap who's previously had an aortic valve replacement and again bypass grafting. He has a severely impaired ventricle and this time has an implantable defibrillator. He's had gradual deterioration. He's had 4 admissions over this time, of varying lengths from a week up to sometimes 3 or 4 weeks, all with heart failure and a degree of renal impairment. His albumin's falling and he has chronic renal. His weight is again increasing over the last week or so and he called REACT. Despite IV diuretics, his renal function continued deteriorating. Ultimately, he was MHA class 3 to 4. We made a referral on to palliative. And the reason I brought this case up is to discuss device therapy and end of life. The important thing is there's no right answer to this. And I think it's very important to look at multiple influences before making a decision. For example, before you switch a patient's ICD off, you might want to know how much arrhythmia burden there's been. Has it been over the last few days, the few weeks, months, or even 5, 6, 7 years ago? Have we had any recent medication changes that might make arrhythmias more likely? For example, if he's intolerant to amiodarone and beta blockers and these have had to be stopped, and influence your decision to switch off patients' devices. And I think the most important thing is to have an honest discussion with the patient. As health professionals, we often feel that this is clearly the ends of their heart failure journey and they clearly should be considered for device deactivation. However, I think patients' perspectives change. For example, when they reach this end stage heart failure, they have different goals, often governed by family events and similarly by their ability to potter around the house and switching to bedbound. When this happens, they often do agree that the device should be switched off. But up until then, if I tell the patients, look, you're really at the end of your journey with heart failure, they often would be happy to switch their device off. But then if I tell them, you might have a dangerous rhythm problem tomorrow and not wake up, then they actually say, I'm not quite ready to die and I'd like my device left on if that's okay. It's also important that, for me, ICD deactivation is not the same thing as not for CPR. In the UK now, when a patient's admitted to hospital, particularly with the COVID pandemic, we have made decisions very quickly about resuscitation or not for resuscitation and ceilings of care. I tell all my heart failure patients, particularly those with devices, that not for resuscitation does not mean the same thing as switching off your ICD. And it's important that other healthcare professionals see this. I specifically tell them that ICD deactivation is really a decision with the family and often our arrhythmia nurse rather than anyone else being involved, and we have a specific deactivation policy within our trust. So it's quite a good opportunity to discuss this openly and frankly with our arrhythmia nurse and myself. The discussion should still be very open with the patient and family, particularly if they have capacity. And interestingly, if you ask healthcare professionals, they have very differing views. So some feel that not for CPR is the same thing as switching off their ICD. But interestingly, for example, a patient dying who has a renal transplant, we don't remove this. So once it's become part of the patient, I think it's still ultimately up to the patient to make that judgment if he has capacity. this might be a surprise to many of you. Patients who have ICDs tend to die of natural causes, including those patients with advanced heart failure. The vast majority have no device therapies. They have a very peaceful death and die from PEA or asystole without any need for the device to be switched off. Obviously, if feasible, we do, but it's important that actually a rhythm disturbance during the final stages of life is very infrequent. I suppose the question is what to do if a patient is having an. I think it depends on how the patient is. So depends how symptomatic and distressing those rhythm disturbances are. If the patient is clearly having shocks, you have to do something about it. One thing possible is to place a magnet over the device, which will terminate all tachycardia therapies. Bradycardia therapies will persist. Remember, though, that if you did this, the next time the patient had a rhythm disturbance, which could well be in a few minutes, the patient will die, or potentially die. So you have to be prepared for this, and it's obviously quite a difficult time. Importantly, even a patient at home whose device is going off at end of life will only have 6 to 12 cycles of therapy before the device stops giving further therapies and assumes the patient's died. Back to my patient, I had a long discussion with the patient and family, with both my arrhythmia nurse and heart failure nurse specialists present. It's important to have a team approach, particularly with people that patient and family have got used to over the years. The patient was still keen to pursue active treatment. He understood that I might be prolonging the inevitable, but nevertheless we admitted him to coronary care. I gave him 7 days of IV diuretics and inotropes. We did provoke some VT, but ultimately I managed to get 6 kilos off him with symptomatic improvement and some renal function improvement as well. He was discharged home on the 23rd of December. He was readmitted in January, back in the same position, and this time, despite inotropes, there was no response to weight and his renal function continued to deteriorate. We had another long, frank discussion about where he'd like to be, and with palliative team support, we managed to get him home with a full care package, including oxygen. His wife and family were still struggling to cope with him, mainly because of confusion and delirium, and he was moved to the hospice. I visited him the night before his death, and his wife and 3 children were present on his. Even though to an outsider, I suppose, might feel that this multiple admissions, I was prolonging the inevitable. I suppose in essence I probably did, but it was exactly what the patient and family needed. I had letters to the MP and to the trust saying how thankful they were that they had to have one Christmas at home, and the family was so grateful for their time with. This brings me to one of my most interesting cases. It's a 78-year-old chap, again with coronary artery disease, with bypass grafting and recent intervention. He also has quite chronic airways disease. Had an ICD implanted 5 years prior as a primary prevention tool. He was MYHA2 independent, walking to the shops. 2 admissions with acute shortness of breath, with his CRP elevated, and was treated for an exacerbation of his airways disease as well as heart failure. He gradually improved over each week and was discharged after each admission. On this 3rd admission, with heart failure, he was deteriorating again, and the family felt this was really end-stage heart failure. They were very, very keen for him to get home with a palliative care package. I spoke to the family and the palliative care team and said, look, are you sure you don't want me to try one more trial of aggressive treatment to see if we can turn things around? They were awfully keen that we just leave things alone, and the palliative care consultant clearly told me that this is really the last few days. We sent someone home to deactivate his ICD, and we assumed that was the end of it. However, he turned up to his ICD appointment, which we'd forgotten to cancel. He was actually back to his baseline, going to the shops, walking, and doing very well. The cardiac techs phoned me up and said, this chap is here, his ICD switched off, what do I want to do? So I had a long chat with him, and we switched his ICD back on. 12 months later, he had some VT, so this is a rhythm strip from the device itself, and this is a very fast ventricular rhythm with a cycle length of 150, 160 milliseconds. The device was in the VF zone, and ultimately a 38 or 35 joule shock was administered and returned back to sinus rhythm. Was doing pretty well. His ICD was ultimately reaching end of life. His underlying ECG was broad, and I actually upgraded him to a CRT device, one of those cardiac resynchronization ones. 2 years later, he started to deteriorate from advanced heart failure, and he was seen in REACT last year, and at this stage referred to St Barnabas, our community hospice, and he died at home with no hospital admissions. So this was 4 or 5 years after his device was switched back on. The difference really is that despite everything we know that advanced heart failure behaves like cancer, there's still some things that we can't quite predict, and sometimes it's not all over. This brings me really to my take-home messages. The first thing is, if you've got someone that's deteriorating or semi-deteriorating with their heart failure, the first thing to exclude is there any underlying ischemia? Lots of these patients have ischemic cardiomyopathy, have had previous intervention, and it's one of the first. If you do find ischemia from perfusion scans or even MRI, it can be difficult to treat in this advanced stage, often with bypass grafting. So I do ask my interventional colleagues to perform pretty complex interventions, but often this can improve in some LV function and symptoms, particularly if there's reversibility. Something that's really important to consider is arrhythmias. So both slow chronic VTs as well as inadequately controlled atrial fibrillation or new AF. These can both be treated pretty successfully. The atrial fibrillation, there's lots and lots of good evidence, in fact probably the most evidence, where AF ablation can make dramatic improvements to survival in the heart failure population. So Castle AF, ATTAC and camera MRI have shown significant improvements if you aggressively treat patients with atrial fibrillation. Often this is quite complex ablation and often more than one sitting. It may be feasible to use echo and MRI to predict those with good response, looking at left atrial size, late GAD, enhancement for scar burden. Importantly, don't forget restoration of sinus rhythm, which is often easy to do with a course of amiodarone and cardioversion. These patients won't be on amiodarone for long because it's end-of-life care, and any benefit is a bonus. This brings me to CRT optimization. This is something I consider occasionally when we've exhausted all other options, and it's often quite hasn't been switched on. I sometimes do this with echo, RV and LV delays, particularly in patients with AF, as sometimes the device can struggle to auto-optimize in these conditions. I have had some anecdotal evidence that patients feel better, but maybe this is through placebo effect rather than actual good, strong evidence. My final thoughts really are to look at other symptom treatments. So iron therapy can sometimes be of benefit. And finally, if it's a young patient that's definitely feasible for cardiac transplant and LVAD, I refer on to our tertiary heart failure transplant centre. I suppose the important thing is to remember as heart failure progresses, there will be a time to consider switching to end-stage heart failure treatment goals, and instead of considering treatment in disease progression, it's really a switch to symptom-driven treatment with stopping ACE inhibitors, statins and spironolactone, and titrating up the diuretics, the oxygen and the opiates with less care about renal function, etc. It's important also to discuss trajectory of the patients and family. As I've mentioned, discussion about device deactivation can be difficult. And finally, end-of-life planning, readmissions to hospital, ceilings of care, place of death, involvement of the palliative care team and hospice, and sometimes even giving a magnet for the family to use if necessary. Thank you very much. Any questions?
With that, we have come to the end of the symposium, very interesting symposium. I'm sure all the 4 lectures were outstanding and help us to understand the heart failure better and manage our patient with heart failure in a better way. So it's time to show appreciation for the resource person. Only Dr. Vasantha Disanayak is here. So can I ask Dr. Vasantha Disanayak to come to the stage? My co-chairperson would hand over the certificate of appreciation to Dr. Vasantha Disanayak.
Good morning. Welcome to the first 2 plenary lectures of the second day of the SIMCON 2020. First one is, because I just wanted to give a brief introduction. Sepsis is an overwhelming reaction to infection that comes with high morbidity and mortality. So it requires early diagnosis with urgent investigations. So Surviving Sepsis is an international campaign that aims to improve the sepsis outcome. So I cordially invite Dr. John Hunninghake to elaborate us on sepsis, a 2020 review for the internist. Over to you.
All right. So hello, my name is John Hunninghake. I am a pulmonary and critical care physician out of San Antonio, Texas, and also a fellow of the ACP. I will be presenting Sepsis, a 2020 review for the internist. In terms of my disclaimers, as a member of the US military, my views do not reflect those of the US government in regards to this presentation. Also, I have no personal disclosures with regards to the content of this presentation. Although I am a huge Chiefs fan for American football, unfortunately they haven't done so well in the Super Bowl. So here is a list of my learning objectives. I will be discussing a lot in 30 minutes, and I hope to introduce you all to some more information that can be further reviewed on your own time. While my main objective is to provide important context for sepsis diagnosis and management based on the most recent guidelines from 2016, I'm also hoping to highlight key changes over the past few years that are clinically relevant. I'm going to be talking about the epidemiology, diagnosis, and then the management, but then also talking about how these practice-changing updates affect the management from the bedside, and ultimately applying this sepsis knowledge to the rapidly changing environment of the COVID-19 pandemic. So sepsis is a substantial global health burden. It is a leading cause of death, morbidity, and expenses, as highlighted by the largest study of sepsis inpatient admissions ever reported in a 2020 article in the journal Critical Care Medicine, which analyzed data from more than 9.5 million hospital admissions. It found that sepsis not only predicts high mortality during a hospital admission, but also a poor quality of life after the admission. Sepsis is the primary cause of death from infection, especially if it is not recognized and treated promptly. Its recognition mandates urgent attention. But in order to recognize sepsis, we must start with a standard definition. Consensus definitions and guidelines for sepsis were originally generated in 1991 and then revisited again in 2001. Since 2001, considerable research advances had been made in sepsis, and in 2014, a task force was convened to provide a standardized definition of sepsis and then provide the tools for clinical operationalization and diagnosis. This content was eventually published in an article called Sepsis 3 in 2016. At that point, sepsis was redefined as an aberrant or dysregulated host response in the presence of organ dysfunction. The new definition of sepsis ultimately reflects an updated view of pathobiology, which is reflected here and its association with the clinical syndrome. This was highlighted in a 2018 Lancet review, and it particularly identifies what distinguishes sepsis from an uncomplicated infection. So here are the SIRS criteria, or systemic inflammatory response syndrome, from the original 2 sepsis definitions, which were officially replaced in the 2016 guidelines by the SOFA and QSOFA, or Quick SOFA criteria. The SOFA score was recommended by the new guidelines to diagnose sepsis as it had been validated clinically. A higher SOFA score had been shown to be associated with an increased probability of mortality. The score grades abnormalities by organ system and accounts for clinical interventions. This is the clinical pathway that was suggested in Sepsis 3 as a simplified way to approach the new definition and diagnosis of sepsis that correlated with routine patient care, but also allowed for utilization by researchers, administrators, and funders. So separately, the Surviving Sepsis campaign was begun in 2002 to reduce mortality from sepsis through multiple initiatives. The cornerstone of this campaign has been the publication and subsequent implementation of regularly updated evidence-based guidelines, first published in 2004 and most recently in 2016. As shown by this diagram, it shows how there are many layers to the Surviving Sepsis campaign guidelines and many contributors from all across the world. This figure demonstrates how the guidelines document can be utilized to satisfy the needs of multiple categories of users, as defined by those different layers. Now, here is the summary of recommendations from the most recent guidelines in 2016 that address the main topics of screening, infection management, fluid resuscitation, and vasopressors. I want to highlight the starred recommendations that are strong recommendations. So starting off with screening for high-risk individuals, it's important to identify those tools that screen the best and most accurately, and then have performance improvement projects or initiatives that allow for individual hospitals to identify what works best in their environment. Second, in regards to infection management and source control, cultures are so vitally important before the initiation of antimicrobials, albeit IV antimicrobials should begin within that first hour of recognition, as starred as a strong recommendation. Ultimately, empiric broad-spectrum antimicrobials should be initiated first and then narrowed based on the culture data. And then for non-infectious etiologies of sepsis or SIRS-like syndromes, no antimicrobials should be initiated, as, for example, pancreatitis. Generally speaking, a 7 to 10 day course should be adequate for sepsis management. However, there are certain variables that could suggest a longer course. And then the lab marker of procalcitonin can be utilized and has been shown to help discontinue or shorten courses of antibiotics. Third, with fluid resuscitation, it has been shown to be a strong recommendation that crystalloid should be given first, and then albumin should be added if necessary, especially in patients with a low albumin amount. And ultimately, it has been shown to potentially cause harm to add hydroxyl starch. And then finally, on the topic of vasopressors, norepinephrine has been shown to be the best first-line pressor. Adding vasopressin and then epinephrine are the next best second and third line vasopressors. Dopamine can be used for highly selected patients, but not specifically for renal indications. And ultimately, dobutamine could be utilized for persistent hypoperfusion. This figure from the user's guide to the 2016 guidelines explores the nuancing of initial administration of that 30 milliliters per kilogram of crystalloid for a sepsis-induced hypoperfusion based on patient characteristics. It also draws attention to reassessment tools following the initial fluid dose as an influence on further fluid administration or inotropic therapy. Additionally, here's another figure that demonstrates how the guideline recommendations on vasopressors and steroid use can be molded into a flow diagram approach based on the management of septic shock. I really like this diagram from the British Medical Journal, published in 2016, because it provides a great pictorial overview of all the additional fundamental components of sepsis management that we know does or does not have evidence to support them in terms of helping with patient outcomes. All right, so next we're going to talk about the early recognition and management of sepsis and the analysis and comparison of these screening and detection tools that are out there and from more recent data. So first off, in 2018, Critical Care Medicine published a statement that endorsed the 1 hour sepsis bundle as compared to a 3 or 6 hour bundle, as the 1 hour bundle demonstrated an association between bundle compliance and improved survival in patients with sepsis and septic shock. This table lists the elements of the 2018 bundle, which are intended to be initiated within that first hour. Specifically for antibiotics, each hour delay resulted in an 8% increased risk to septic shock, as shown in a certain study. Now, for the 1 hour bundle, it is important to appreciate that sepsis is a medical emergency. First, lactate should be measured as a surrogate for tissue perfusion, albeit we'll talk about alternative measures in a more recent updated article, as there is a reduction in measuring lactate and mortality with the lactate-guided resuscitation. However, this is a weak recommendation based on low-quality evidence. Number two, we should optimize the identification of pathogens by obtaining 2 sets of blood cultures before administration of antimicrobials, as cultures can sterilize within minutes of antimicrobial administration, although this is considered a best practice statement. Number three, it is a strong recommendation with moderate quality evidence to administer broad spectrum antimicrobials within that first hour after cultures have been collected. Number four, it is also a strong recommendation, but with low quality evidence, to start immediate intravenous fluid resuscitation with 30 milliliters per kilogram of crystalloid for for hypotension or lactate greater than 4, especially within 3 hours of diagnosis, albeit the 1 hour bundle pushes it to within 1 hour. And finally, vasopressors should be utilized to restore adequate perfusion pressure with a mean arterial pressure or MAP goal of greater than 65 millimeters of mercury if the patient is hypotensive during or after intravenous fluid resuscitation. And I'll talk about a study here within the past year or two that identified a clinical pathway for this. So what is the best tool to avoid delays in the recognition of sepsis? In this 2020 study out of Critical Care Medicine by Prasad et al., they looked at the SIRS, SOFA, and QSOFA scores on presentation to the emergency department and then subsequent outcomes. They found that SOFA or SIRS scores alone will delay antibiotic administration. Therefore, a combination of SIRS and SOFA was found to enhance timely identification of sepsis in patients presenting to the emergency department. So what is the best tool to recognize sepsis early to initiate management? This chart summarizes the evidence behind the different scores and compares the trade-offs. Many hospitals use the MUSE or NEWS scores because they are the most accurate score that we have commercially available. However, recognize that computerized algorithms with machine learning are highly accurate models for identifying patients with sepsis. Unfortunately, they are not widely available. Here's an example of a sepsis screening tool in the clinical pathway. This is publicly available on the Surviving Sepsis Campaign website under the Resources tab. I highlight this next example because it includes the quote code sepsis end quote pathway that stresses how it is a medical emergency similar to a code blue. And finally, I include a screenshot here from the Surviving Sepsis Campaign app as a point of care reference to be able to look at the different resources and utilize them at the bedside. So next, let's talk about the updates from some of the randomized controlled trials that occurred over the past few years but are relevant for 2020 and the review for you all. Specifically, we're going to talk about the topics of fluid responsiveness, capillary refill, peripheral vasopressors, steroids, and IV vitamin C or adjunctive therapies. So first, here's a trial that I referenced earlier that was published in Chest in early 2020, which tested a clinical pathway for identifying fluid responsiveness in patients with sepsis as compared to standard care alone. This clinical pathway utilized a passive leg raise and ultimately the stroke volume variation based off of it, utilizing a non-invasive cardiac output monitor or NICOM. By utilizing this information, the goal was to determine whether more intravenous fluid should be utilized or if a switch to vasopressors should be indicated sooner rather than later for patients in the emergency department. Ultimately, the trial had positive outcomes that supported this clinical pathway, especially with regards to a decreased fluid balance and lower utilization of renal replacement therapy in patients. However, one big concern is the funding that was utilized by the maker of the electronic NICOM that was utilized. In another study from 2019 that was published in JAMA, Hernandez and co-authors compared the effect of capillary refill times versus lactate to guide resuscitation for patients with septic shock. This was the Andromeda trial. While they found that a peripheral perfusion target resuscitation strategy utilizing capillary refill did not result in improved mortality, there was a signal towards benefit as seen in the Kaplan-Meier curve. Additionally, I believe that the main takeaway is that capillary refill may be non-inferior to lactate-guided resuscitation in patients with sepsis and septic shock, which could have huge implications in hospitals that do not have lactate readily available. Especially, and this at this point is especially important in patients with a higher Apache score, as shown by the hazard ratio plot. Now, I'm not sure about y'all, but we always have questions from other physicians and the nurses about the safety components of using vasopressors through a peripheral IV before we have a central line, especially early in the resuscitation process for patients with sepsis. In 2019, there was a large meta-analysis that demonstrated relative safety with this practice, as extravasation occurred in only about 3% of cases and did not result in tissue necrosis or limb ischemia. Now on to steroids. Whew, this is a big topic. I'm going to try and fit it in just a few slides, and know that there's a lot of context that I will try and review very quickly. So there are multiple randomized controlled trials that have investigated the potential role for steroid therapy in patients with septic shock. Most trials found a faster resolution of shock for patients when utilizing steroids, but no mortality benefit was really identified except for 2 trials that also utilized fludrocortisone, one early in 2002 and one more recently. In addition, there was a meta-analysis here in about 2020 that confirmed a moderate benefit from hydrocortisone of doses 200 to 400 milligrams a day for 4 to 7 days in patients with septic shock. So here are the 2 landmark trials that were published in 2018, both in the New England Journal of Medicine. Approx randomized over 1,200 patients to IV hydrocortisone and PO fludrocortisone and showed an absolute risk reduction of 6% in mortality at 90 days, which resulted in a number needed to treat of only 16. The trial also demonstrated faster reversal of shock and organ failure, which aligned with the other trials. In the same edition of New England Journal of Medicine, although published earlier online, the adrenal trial included over 3,800 patients that unfortunately demonstrated no difference in 90-day mortality when using hydrocortisone alone. So what about adjunctive therapies, specifically intravenous vitamin C, specifically high dose, and thiamine? Ever since Merrick's provocative study from 2017 demonstrated a significant mortality benefit of 8% for his triple cocktail with IV vitamin C, hydrocortisone, and thiamine, compared to 40% alone in a case control study, there has been a lot of interest in this area with IV vitamin C. Unfortunately, there have not really been any studies that found a similar effect on mortality, including a meta-analysis from 2019 that evaluated over 6,400 patients. Albeit, as with many meta-analyses, there was a significant amount of heterogeneity that was attributed to as the potential for confounders. So in 2019, Fowler and colleagues published an article, a study called the Citrus ALI or Citrus ALI study in JAMA. This study randomized patients with sepsis with ARDS to IV vitamin C or placebo. And it looked at changes in SOFA scores, inflammatory biomarkers like C-reactive protein, and then vascular injury by looking at thrombomodulin. High-dose IV vitamin C did not significantly reduce organ failure score, but demonstrated a significant reduction in 28-day all-cause mortality that was considered, quote, exploratory, end quote, because it did not account for multiple comparisons. Now, in January of 2020, the vitamins trial was published in JAMA. This trial attempted to more closely replicate Merrick's 2017 trial with IV vitamin C, hydrocortisone, and thiamine in the form of a multi-center randomized controlled trial that compared this triple cocktail with IV hydrocortisone alone in standard therapy. Unfortunately, it did not find a mortality benefit similar to Merrick or at all, nor a more rapid resolution of septic shock compared with patients treated with hydrocortisone alone. All right, And finally, the elephant in the room, the COVID-19 pandemic. It is hard to talk about sepsis in the year 2020 without mentioning the viral sepsis syndrome caused by COVID-19 that has a significant amount of overlap in treatment with non-COVID sepsis and septic shock. There are multiple guidelines out there that generally align on the majority of topics, including Surviving Sepsis Campaign, the NIH guidelines, which were recently updated in January of 2021, and the WHO guidelines that were recently updated in January of 2021. I'm not going to discuss the guidelines in detail, but will mention some important components of COVID-19 and its relation to sepsis. As this infographic from the British Medical Journal demonstrates, sepsis and septic shock define the critical phase of COVID-19. Most guidelines agree that treatment of sepsis and septic shock should be similar in COVID and non-COVID cases with regards to our approach with fluid resuscitation, antibiotic utilization, and ultimately use of vasopressors in these patients. All right, so what are my conclusions and takeaway learning points? Sepsis and septic shock are severe, overwhelming, heterogeneous reactions to infection that represent a significant global health burden with a high morbidity and mortality. Awareness, early recognition, timely interventions in the form of standardized bundles lowers this sepsis mortality. There are multiple recent studies in the past few years that have provided additional insight into sepsis diagnosis and the management through measures of fluid responsiveness, physical exam maneuvers, and potential adjunctive therapies. We hope to have more studies in the near future that will help influence the next iteration of guidelines to provide a more clear clinical pathway with how to treat these patients as best as possible with the best outcomes. Here's a list of a select few of my references. Thank you so much for your time, your attention. I'm happy to answer any questions that you have. Feel free to email me, and I hope you enjoy the rest of your conference. Thank you.
Thank you, Dr. John, for your excellent lecture on sepsis. So to conduct the next plenary, I would like to invite Dr. Madhuvanti.
Thank you, Manoji.
Now we have come to the last talk of this symposium. May I introduce Dr. Anuj Maheshwari. He is the professor and the head in medicine, BBD University, Lucknow. Over to you, sir.
Okay, thank you. Thank you, Chairperson, for the kind introduction. And thank you, Dr. From the College of Sri Lankan Internal Medicine, Dr. Suranga, who has invited me here. as a speaker. So I'm going to share my slide set. Hope you can see my slide set.
Yes, we can see.
Okay. So in next 20 minutes, I shall be talking about the ABPM. ABPM means ambulatory blood pressure monitoring. Why should we do it and how to interpret it? Our main focus shall remain there to interpret of ambulatory blood pressure monitoring. There is no financial disclosure regarding this talk, but I have spoken in past few of the Omron Academy talks with receiving honorarium. So when we talk about the blood pressure, this is a thing which has been done and being measured for a long time. The measurement of the blood pressure is likely the clinical procedure of the greatest importance, but that is performed in the sloppiest manner, which has been said in 1998 by N. Kaplan. And since then, we know multiple methodologies of the measurement of the blood pressure, multiple instruments, multiple technologies has been arrived. Earlier, when we were growing up, we were told that mercury sphygmomanometer is the gold standard of the blood pressure measurement. But when it has been switched to the ambulatory blood pressure monitoring, we could not even notice, and many of us could not even knowing now that now the gold standard of the blood pressure measurement is the ambulatory blood pressure measurement, not the mercury sphygmomanometer. What is in the new recommendation? It has been 2011 when NICE recommendation has said that if you are keeping your patient's blood pressure more than 140/90, who has been previously undiagnosed, but it is less than 180/110 millimeter of mercury, it must be confirmed with the ambulatory blood pressure monitoring. In 2015, Canadian guidelines has said that clinical blood pressure should be using electronic monitors. At the same time, they also said that diagnosis of the hypertension should be based on the out-of-office measurements. So now the office measurements of the blood pressure is out for the diagnosis purpose. Out-of-office assessment is the preferred means of the diagnosing hypertension. Anytime, if we are finding any patient who is having blood pressure high in office or in home or in our pharmacy, he must be explored for the history and his physical examination. He must have been explored for the medication what has been taken in recent past. Probably some medications might have caused a transient raised blood pressure. Apart from that, he must have been told or he must have been asked or inquired about the test which has been undergoing in the past, like some of the contrast media may also raise the blood pressure for a short while. Again, the same parameters will be followed. If your patient is having the blood pressure more than 180 systolic and 110 diastolic, is clear-cut hypertension, whether it is office measurement or home measurement or pharmacy, it is not required to be confirmed with the out-of-office assessment. But if the blood pressure measurement is more than 135/85, which is the cutoff for the automated office blood pressure measurement, and 140/90, which is the cutoff for the conventional methods of the office blood pressure measurement like mercury sphygmometer or LED sphygmomanometer, then it must be confirmed once by the out-of-office assessment, maybe it home blood pressure monitoring, or better or preferred method is the ambulatory blood pressure monitoring. There are different criteria also for the measurements of the different methods for the clinical blood pressure measurement, home blood pressure measurement, and ambulatory blood pressure measurement. Whenever you are measuring the blood pressure in your clinic, the cutoff may be 140/90 millimeter of mercury. In home, while doing with the automated blood pressure monitor like oscillometric blood pressure monitor, you can make it cutoff, which is recommended by international recommendations, 135/85. But at the same time, when you are doing it with the ambulatory blood pressure monitoring machine, it should be for the 24 hours less than 130/80. For the daytime, it can be accepted up to the 135/85, but in the night time, it should be 120/70 or less than that. This is the picture of the ambulatory blood pressure monitoring, what I can show it to here. This is the machine on the left side of this picture. And 24 hours of blood pressure monitoring is being done, which is to be connected with the computer, and then you can know about the 24 hours the blood pressure performance of the patient. You can also identify the dippers and non-dippers, which I shall be elaborating in the next slides in detail. And of course, the white coat hypertension can very well be excluded, which is normally seen raised blood pressure in the doctor's clinic, but otherwise it remains normal. So what is behind this dipping and non-dipping? Physiologically, blood pressure falls by more than 10% during sleep. When BP falls by less than 10% during night time, it is defined as non-dipping. So fall of blood pressure during the sleep in the night time is mandatory. If it is less than 10%, you are on the risk. It is called non-dipping. And if it is more than that, it is again also causing harms. Prevalence of the non-dipping is more commonly seen in the diabetic patient. Approximately 30% diabetic patients are having this. ABPM, ambulatory blood pressure measurement, is the best way to identify white coat hypertension, masked hypertension, non-dipping, or sometimes the extreme dipping. This is the first picture what I can show you as a result of the ambulatory blood pressure monitoring machine, in which you can see the systolic hypertension continuously is there while diastolic hypertension is not. Diastolic blood pressure is keeping in the normal limit. But here you can see that there is a dip in the diastolic, midnight dip in the diastolic, but this midnight dip is not visible in the systolic hypertension. This is a picture of the isolated systolic hypertension. But whenever we go for any patient's ambulatory blood pressure measurement, we must ensure minimum 21 daytime readings should be recorded with 7 nighttime readings. Minimum number is the 2 readings every hour. In our clinic, what we follow that we do readings every 20 minutes in the daytime and every 30 minutes at the night time. Percentage of the successful reading should be at least 70% or higher. So minimum 70% reading should be telling you the results. When we talk about the nocturnal hypertension, that is the more dangerous things and conveys the worst higher prognosis regarding the 24 hours blood pressure. Many of the times we see that 24 hours blood pressure may not be very high. Even the daytime patient is keeping the blood pressure 130/80 or 135/80. But if it is not dipping during the night time while sleeping, then it is an indication of something wrong is going to occur. The absence of the normal dipping and dipping magnitude predicts that mortality in the hypertensive patients higher. This is another example of ambulatory blood pressure monitoring. What we can see normally in our day-to-day routine patient is this is a patient who is having the normal blood pressure, but this patient is having a tendency of getting the high blood pressure after the exercise, because whenever it has got the spike of the systolic hypertension, he has been found to be having history of little exercise or being exertion done there, for which it has got increased the little bit increase in the blood pressure, especially in the systolic, and there is some increase in the diastolic also at some places. So this patient has been told not to do the exercise while he is keeping on the ambulatory blood pressure machine on a steady period. But at one important thing you can notice in this patient, in the morning time, this patient is keeping his blood pressure high. And this is the signal of bad thing is coming up. This is the signal that this patient is going to be the hypertensive in very near future. The prognostic significance of the clinical measurements over the ambulatory blood pressure measurement has been analyzed. In fact, by the multiple meta-analysis, it has been established that ABPM is having more prognostic significance over the clinical measurement as the blood pressure starts rising. You can see it here. As the blood pressure is going up and up, the prognosis of the ambulatory blood pressure monitoring is becoming more and more important. We know that sustained hypertension is detrimental, made to be measured by the home blood pressure or in the office blood pressure. But very few of us know that mass hypertension and white coat hypertension are also having the same detrimental effect over the end organs of the body as the sustained hypertension have. Both white coat hypertension and mass hypertension has been independently associated with increased aortic stiffness, renal injury, and incident cardiovascular events. Here you can also see that prognosis of the mass hypertension, which is just short behind the hypertension or sustained hypertension. Although white coat hypertension having little less bad prognosis or little less relative risk of the cardiovascular disease as compared to the mass hypertension, as mass hypertension is having significantly higher than the white coat hypertension. The overall prevalence of the mass hypertension is approximately 10% in the general population, but is higher in patients with diabetes. If we compare this ambulatory blood pressure monitoring with the clinic blood pressure monitoring, we see that the people, those who are not taking the medication, where ambulatory blood pressure monitoring is a better reflector for the hypertension or requirement of the medication as compared to the clinical blood pressure monitoring. You can see that people, those who are taking the clinical blood pressure measurement or who are monitoring themselves with the clinical blood pressure, they keep on doing for the without medication even when they are requiring those medicines. Simply the people, those who are having the multiple drug treatment, again the ambulatory blood pressure monitoring is having better predictor as compared to the clinical blood pressure monitoring. Cost effectiveness has also been found to be the ambulatory blood pressure monitoring. Let's see a person's ambulatory blood pressure record who has been the normal. This is the picture of the normal person, where you can see that systolic and diastolic both blood pressure were normal. Only a small rise has been seen at in the morning hours. Is a very non-significant kind of the rise. So this is the normal picture or normal study of the ambulatory blood pressure monitoring. But again, you can see this is the patient who is having a hypertension in the morning times. This patient is going to be the future hypertension. Very soon he has been the hypertensive. That's why we always say whenever is there home blood pressure monitoring or the blood pressure monitoring in the office, it should be done in the morning time more preferably. So this is the reactive hypertension and most likely to be on the risk of hypertension soon. This is the picture of another hypertensive patient where you can see that the loss of midnight dipping is being there. Although there are the few of the episodes of the hypertension in daytime, but in the night time you can see there is no dipping and patient is having a complete loss of the dipping. This patient is on the higher and higher risk, although he is not showing so much of the hypertensive episodes here. Another important thing, you can see that if this patient comes to you at your clinic around 7 p.m. or 8 p.m. or in the evening time, probably you will be measuring every day his blood pressure normal, because he is keeping his systolic and diastolic both normal at this time. After going home from the office, if he is measuring his blood pressure, he is finding normal. But at the rest of the time, he is keeping his blood pressure very high, and this can only be detected by doing the ambulatory blood pressure measurement. Why should we do ABPM in the diabetic patient? 65% of the type 2 diabetic patient have the systolic hypertension. And systolic hypertension is a better predictor, a stronger predictor of the cardiovascular adverse end outcomes, which are challenging to the control. Diabetic patients are more likely to be the non-dipper, and therefore office BP measurement do not reflect the real cardiovascular risk. White coat hypertension seem to be less frequent, and mass hypertension is more frequent in diabetic patients, and which is really more detrimental also, as I have shown in the previous slide. Depression is more common in diabetic patients. Clinical inertia is a big problem in patients with the diabetes. Many of the time we keep our focus on the glycemic control, forgetting about the blood pressure measurement, even the blood pressure control. This is another picture in which we can see the systolic and diastolic both hypertension most of the time in the day. And this is the non-dipper person. And this non-dipper, as I already told you, is more harmful as compared to the dippers and the people, those who are keeping their blood pressure high, but having a normal dipping. So nocturnal hypertension or nocturnal non-dipping is associated with increased risk of the stroke, increased risk of the end organ damage, and increased risk of the cardiovascular events, as well as death. Type 2 diabetes, obesity-associated obstructive sleep apnea, orthostatic hypotension, diabetic nephropathy, heart failure, autonomic neuropathy, all these are the common reasons of non-dipping or nocturnal hypertension. So that's why nighttime blood pressure is more predictive for the mortality as well as cardiovascular adverse outcomes. dipping status can be analyzed by a person is called normal dipper if he is having 10 to 20% dipping between the daytime to the nighttime average. He will be called non-dipper if it is less than 10% of the dipping. Reverse dipper if he is having a rise in blood pressure at the night. Extreme dipper if there is a more than 20% dipping. And this more than 20% dipping may be associated with mild cognitive impairment in the elderly. And many of the times we see the people, those who are keeping their blood pressure at the very high level, sometimes with the arterial stiffness, sometimes together with the arterial stiffness or other reasons also may be related to the CKD, all that. They have this 20% dipping or more than 20% dipping in the night time, and they are associated with the cognitive impairment. Ambulatory blood pressure monitoring indication, when we should really go for the ambulatory blood pressure monitoring. Although now present guidelines says that every hypertensive or borderline hypertensive must be confirmed with the ambulatory blood pressure monitoring, but exact indications may be one, to make the diagnosis of the hypertension. Apart from that, to rule out the suspected office hypertension or white coat hypertension, to evaluate the borderline hypertension with end organ damage, to investigate the labile or paroxysmal hypertension, to evaluate symptoms possibly related to the blood pressure fluctuation, especially the orthostasis, to evaluate orthostatic hypotension, autonomic dysfunction, carotid sinus syncope, and follow up the adequacy of the antihypertensive therapy. Ambulatory blood pressure monitoring is very, very much useful when we are dealing with the resistant hypertension, which is many of the times is because of the poor compliance of the therapy. This is another picture in which you can see that isolated systolic hypertension. But as I already said that what if this patient is more than 80 years of the age? This can be a normal routine phenomena, but always remember if the dipping is more than 20%, it is going to be a big problem for this patient. This patient will be facing the autonomic dysfunction. At the same time, they will be suffering with the cognitive impairment with this. And by reducing the blood pressure in the daytime, you can reduce this 20% fall in the nighttime also. And that's why present recommendation says, irrespective of the age, the 130/80 should be the cutoff for the hypertension management, target for the hypertension management, may it be whatever the age the patient is having. Systolic and diastolic both are showing the hypertension, tachycardia, negative chronotropic agents may be more useful in such kind of the situation, and this picture usually seen in the young hypertensive when beta blockers or non-dihydropyridine calcium channel blockers like verapamil, diltiazem could be of more use. This is a wonderful picture where you can see that normal blood pressure across the day, but at the night time this blood pressure is very high. You can see it here that when it should be the dip, but the patient is having the high blood pressure. And this is the picture of the autonomic failure in the Parkinson's disease in the old age. So how to analyze these reading ABPM which are coming up? If we can summarize this, we should check for a valid number of the readings, and especially those who are in the sleep time and awake time. As I already said that sleep time should be little lesser, but 7 readings should must be there, while the 21 times should be in the awakening time. Check the overall blood pressure, daytime BP, nighttime BP to ensure the targets are being met or not. Checking the dipping status, sometimes you can give the medication at the bedtime if a person is non-dipper. Check the heart rate and adequacy of the control because it will be related to the another choice of the drug. For the practical consideration, use the non-dominant arm unless the dominant arm has 10 millimeter of mercury or greater blood pressure compared to the non-dominant arm. Have the patients keep a diary, adjust the setting to correspond to bedtime and time awake. Ask the patient to stop and stand still when a reading is being taken. Suppose a cuff is started to be inflated, then patient should stop the movement. He should stand still at wherever he is without talking to anyone if possible. Go about their daily routine, but ask them not to do the exercise. Test an initial reading to be sure it's working. Use a proper sized cuff. A thin sleeve over the arm and under the monitor helps prevent bruising over the skin. So advantages of this ambulatory blood pressure monitoring over the clinic measurements, ABPM eliminates observer's bias. It provides information on the BP level and heart rate throughout the day. It provides a superior assessment of the true blood pressure, provides information on the blood pressure variability, circadian rhythm, circadian changes, and the effects of the environmental and emotional conditions on the blood pressure level, what you can never measure over the clinic measurement or even in a home blood pressure monitoring also. This is the stage 2 hypertensive dipper, where you can see that daytime blood pressure is too high while the dipping is going to be highly compromised here. This is the hypertensive non-dipper, where you can see that all the time, all the 24 hours, the blood pressure variability is the least, and it is really keeping the same level in the midnight what is keeping in the daytime also. So contraindications or the barriers of the ambulatory blood pressure monitoring when we should not go for the ambulatory blood pressure monitoring if the patient is non-cooperative. If office blood pressure measurement is too high, more than 180 by 110, then it is not really needed to do. Arm is too big, means we are not having the enough size cuff. Severe peripheral vascular disease and thrombocytopenia is again a contraindication for the ambulatory blood pressure monitoring. It has got its own limitations also, that's why it has not been so popular. Its availability is limited, it is costly, or sometimes it is not patient friendly and sometimes not feasible even to perform. So there has been a study in which the relative effectiveness of the clinical blood pressure measurement, home blood pressure measurement, and ambulatory blood pressure monitoring in a diagnosis of the hypertension has been compared. And in this systemic review, what we could know that clinic or home blood pressure measurement does not have sufficient sensitivity or specificity to be recommended as a single diagnostic test. Clinic or home BP measurements alone might result in substantial overdiagnosis of the hypertension. So treatment decision should be based on ambulatory monitoring before the start of the lifelong drug treatment, labeling a patient hypertensive. It would be more appropriate to go for the ambulatory blood pressure monitoring. And at the end of the talk, if you want to know more about all these factors and you want to get more and more information, we are organizing the 16th Asian Pacific Congress of the Hypertension in India from 26 to 28 November 2021, and you can get yourself registered and you can attend physically also as well as virtually by world-class speakers of the hypertension and KOLs of the hypertension from across the world. Thank you very much for giving me this opportunity to be here. Thank you.
Thank you, Dr. Anuj. Now we have come to the end of the talks. We have about 15 minutes of question time. Because of the time restraints, and may I ask Dr. Sudhat Gunasekara to come over to the podium for the questions from the virtual participants and the audience. May I ask a question, sir? Now, in the clinical setting in the hospital, we didn't go through this encephalopathy and encephalitis EEG changes. Sometimes we see the patients who are unconscious and we are not sure whether they are having some organic disorder or they are a non-convulsive status. So sometimes we request your help. So how do you differentiate with the EEG? Are we going to repeat it several times?
Yeah, EEG becomes very useful in that aspect. If the patient is encephalopathic, there are certain EEG changes which are usually rhythm changes. And if the patient is a non-convulsive status, which may also be associated with the encephalopathy, it may be the result of encephalopathy, they will have ictal discharges. That is one which I showed you last. There are various patterns of ictal discharges, and they are easily identifiable by an experienced person who can read the EEGs. And this becomes actually useful in any critically ill patient. Point I wanted to highlight, and that's a facility you should have in your ICUs. It's a new thing, relatively new thing, not that new, more than 10 years now. In the ICUs, just like you monitor your ECG, you should monitor your EEG to detect subclinical seizures. And as many as maybe 30% of patients who are critically ill due to any cause can have subclinical seizures, and its treatment is important. It has a prognostic implication. So it's easy to identify.
There's another question from the virtual participants. So what are the differences in age in CLCD and other metabolic encephalopathies?
I can see the question. Actually, EEG is relatively non-specific for any encephalopathy. It shows the same changes whatever the cause, whether it is metabolic or whether it is hypoxic, ischemic, or whether it is traumatic brain injury. The EEG changes are more or less the same. But there are certain situations where the EEG becomes relatively specific. One is when it shows triphasic waves. When it shows triphasic waves, as I was about to show some in my slide, unfortunately I couldn't. It indicates usually metabolic cause, some organ failure. So it may be hepatic, renal, or even respiratory, or even sometimes some other metabolic derangements like hyponatremia and so on. They show triphasic waves. So the moment you see triphasic waves, you can think that there is some metabolic derangement that goes on, but it's not possible to identify it as hepatic just by looking at the EEG. So that's one situation where it becomes useful. But there are other situations where the EEG may give a little clue, like extreme delta brushes. Delta brushes are something that is seen in a premature child's EEG. But if you see delta brushes in an adult EEG, then that points to autoimmune encephalitis, especially NMDA receptor antibody encephalitis. Then you have periodic discharges. Periodic discharges, when they are generalized, it points to some generalized insult, but with the clinical picture, you may be able to diagnose something like Creutzfeldt-Jakob disease and so on. And if it is a focal periodic discharge, it indicates a focal acute insult. The focal acute insult means there are only very few differential diagnoses for that, like hemorrhage, infarction, infection, or rapidly growing tumor. So there you have a little specificity.
Okay, thank you, sir. Now the time is up. I think the Sri Lanka College of Internal Medicine has selected a very good topics for the investigations for hospitalists, as well as they have selected eminent speakers, and I think we had a nice symposium today. So on behalf of Sri Lanka College of Internal Medicine, I would like to first thank our overseas faculty for taking their time and giving those lectures, and to our own faculty, Dr. Sudat Gunasekara. May I ask my colleague, Dr. Shifa, to hand over the token of appreciation to Dr. Sudat Gunasekara.